West Nusa Tenggara Province, or Nusa Tenggara Barat, is one of the provinces located in the archipelago of Nusa Tenggara, has two large islands, Lombok Island and Sumbawa Island. There are about 378 smaller islands surrounded. The presence of many beautiful hills, shore and coral reefs with very high economic and tourism potential in West Nusa Tenggara, including Mandalika, which has been declared a special economic zone by the government. Based on an archaeological background in West Nusa Tenggara Province, Faculty of Medicine, University of Mataram, as medical school in West Nusa Tenggara, raised the theme of archaeological medicine as local and unique content in the educational curriculum that was integrated into research and community service activities.
We are very proud to have carried the theme of archipelagic medicine to improve health status and health services not only for our coastal communities, but also tourists visiting our beautiful island, West Nusa Tenggara. We equip the students with knowledge and skills in disaster management, in trauma and environment of marine creatures, decompression sickness, near drowning, and other diseases, as well as knowledge in health referral and evacuation. With our innovative curriculum design, we believe that we can promote a healthier Nusa Tenggara.
To strengthen education, research, and community service programs, we have collaborated with government and private institutions, namely Basarnas, for the National Search and Rescue Agency of West Nusa Tenggara, BPBD, the West Nusa Tenggara Board for Disaster Management, Nipah Public Health Center, Hyperbaric Therapy Center of Regional General Hospital Mataram, Blue Island Clinic of GHI.
In order to implement our vision focusing in developing medical science and technology and excellence in archipelago medicine, we developed a graduate profile, philosophy Pulau, as the abbreviation of professional, universal, leadership, adaptive, and rule of excellence in archipelago medicine. Our future academic activities is divided into 3 activities. One is short activities, secondly is sea activities, and thirdly is undersea activities, which short activities including homeostasis and envenomation of sea creatures, and primary health care on shore. And sea activities include water rescue, disaster management, trauma offshore, and envenomation of sea creatures. And thirdly, undersea activities including decompression sickness and other related diving injuries.
Our dream is to provide the integration of education, innovative research, and health services in coastal and small island area in order to produce the graduate aware and competent in archipelagic health. Now we have several collaboration with several countries and universities in Pacific, and we are open to extending our collaboration with inside and outside the countries to increase the health status of the people in West Nusa Tenggara in particular and Indonesia in general.
Archipelago Medicine, Faculty of Medicine, University of Mataram, for healthy Nusa.
Di tengah perkembangan global yang semakin pesat, Indonesia, khususnya di kawasan Nusa Tenggara Barat atau NTB, menghadapi tantangan serius dalam aspek keamanan kesehatan atau global health security. Berbagai faktor mulai dari resistensi antimikroba, risiko terjadinya pandemi, hingga munculnya patogen baru, semakin memperlihatkan kerentanan sistem kesehatan masyarakat di wilayah ini. Fenomena ini tidak hanya mengancam keselamatan penduduk NTB sebagai wilayah perbatasan dan wilayah penang, tetapi juga berpotensi berdampak pada kawasan lain, mengingat tingginya arus perjalanan antar wilayah di Indonesia. Selain itu, Indonesia adalah negara kepulauan yang terhubung melalui jalur transportasi darat, laut, dan udara yang ramai, memungkinkan penyebaran patogen dengan cepat, terutama ketika terjadi wabah. Risiko pandemi menjadi semakin nyata ketika mobilitas penduduk yang tinggi dan sistem kesehatan yang belum sepenuhnya siap bersatu dalam satu lingkaran risiko. Ketika patogen menyebar dengan cepat tanpa sistem deteksi yang tangguh, wabah dapat berkembang dari lokal menjadi krisis regional bahkan global. Untuk mengatasi berbagai tantangan ini, diperlukan upaya terpadu dari semua pihak. Indonesia perlu memperkuat kapasitas dalam mendeteksi, mencegah, dan merespon ancaman kesehatan. Hal ini dapat diwujudkan melalui peningkatan riset, peningkatan kapasitas sistem kesehatan, regulasi ketat, dan juga kerjasama aktif dengan berbagai organisasi nasional dan internasional. Maka dari itu, hadirlah program studi Magister Kesehatan Masyarakat Fakultas Kedokteran dan Ilmu Kesehatan Universitas Mataram sebagai upaya untuk menjawab tantangan terhadap global health security.
Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera buat kita semua. Selamat datang di jurusan Ilmu Kesehatan Fakultas Kedokteran dan Ilmu Kesehatan Universitas Mataram. Perkenalkan, saya Dr. Apoteker Adriana Rusmadina Hidayati, Sarjana Farmasi, Magister Farmasi, selaku Ketua Jurusan Ilmu Kesehatan. Jurusan Ilmu Kesehatan merupakan institusi pendidikan yang menawarkan berbagai program studi di berbagai level. Salah satunya adalah program Magister Kesehatan Masyarakat yang baru didirikan pada tahun
the honorable speaker, distinguished participants, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. Om Swastiastu.
Shalom,
Namo Buddhaya.
selamat pagi, good morning, and welcome back to Day 2 of the 4th International Conference on Global Health and Innovation 2025.
Proudly hosted by the Faculty of Medicine and Health Sciences, University of Mataram.
My name is Namira and my partner.
Nara.
It is our immense pleasure to serve as your Master of Ceremonies for today's event.
Ladies and gentlemen, before we proceed, we kindly request to all participants to ensure their mobile phones and other electronic devices are set to silent or vibration mode, thus maintaining a focused and respectful environment for our speakers. Thank you for your cooperation.
Ladies and gentlemen, to commence our second day, we are honored to invite the chairperson of the 4th GHI 2025 to deliver the recap of Day 1. To Dr. Mutia Chandra Dewi, Master of Public Health and Tropical Medicine, PhD, the stage is yours.
Good morning, colleagues and participants, and welcome back to the second day of the conference. We're very delighted to see some familiar faces again after an inspiring and engaging first day. While yesterday we focused on non-communicable diseases, including injuries, disaster, and climate-related risk, today we move into day 2 and our discussion shift towards infectious diseases and health security. So we have 2 very exciting plenary sessions and 1 spotlight session with a total of 11 speakers. The first plenary will address integrated strategies to disease control in tropical and island regions with lectures on equitable vaccine access by Professor Olia, developmental origins of health and disease by Dr. Lim, integrated tropical disease response by Associate Professor Gregorio from University of the Philippines, Manila, which will join us online, and also on malaria surveillance by Dr. Henry Suhendra, which also will join us via Zoom. And then after that, we have our second plenary session, which will be even more critical, I would say, and challenges us to think more on how to strengthen health security in fragile and decentralized systems. With speakers on antimicrobial resistance, we have Dr. Shukri with us today, and pandemic preparedness, neglected tropical diseases, and expanding access to surgical and oncological services, with speakers joining online. And the session should cause us to confront the hard question, whether our health system truly resilient, and how do we protect vulnerable population in settings where resources are limited, governance is fragmented, and risk are escalating, all very true realities for us in tropical and island regions. So, and then finally in the afternoon, we will have our spotlight session, which will celebrate emerging voices and innovation in island and tropical health, highlighting fresh perspective from local leaders and young professionals. Yesterday, we also had over 45 oral presentations and 30 posters showcasing diverse research topic, and we would encourage you to join the oral presentation later on and then to see or enjoy your poster walk in the poster gallery during your lunch hours to see what our local researchers have to offer. And with that, I warmly welcome you to day 2 of GHI 2025. Enjoy the rest of your day at the conference.
Thank you to Dr. Mutia for the report. Please have your place on the panel table, Doctor.
Honorable audience, we now begin our main agenda for the day, Plenary Lecture 1 and Panel Discussion 1, which will be moderated by Dr. Mutia.
Dr. Mutia Chandra Dewi is head of the Department of Health Sciences at the Faculty of Medicine and Health Sciences, University of Mataram.
She has collaborated on national and international research projects on drowning prevention, health promotion, and public health in tropical and island contexts.
Okay, to Dr. Mutia, the stage is yours, Doctor.
Thank you. So it will be with me again for our first plenary session on integrated strategies for disease control in tropical and island regions. And we're very lucky that we have 4 esteemed speakers with us. 2 will be presenting on site here in Lombok, while the other 2 will be joining us online via Zoom. And each, I trust, will bring expertise and valuable perspectives to our discussion. I will now introduce our speaker one by one and invite them to the stage. The first speaker will be Professor Aulia Swantika, which you have met yesterday, which was our keynote speaker. Professor Aulia is a professor of pharmacoeconomics at the Faculty of Pharmacy, Universitas Padjadjaran, Indonesia, and also the chair of the Indonesian Health Technology Assessment Committee, and also the vice president of HT Asia Link, which is a regional cooperative network composed of health technology assessment agencies across Asia. Other accolades by Professor Aulia, which is an active member of WHO technical advisory groups on measles, rubella, microarray patch, and for maternal, newborn, child, and adolescent health and nutrition. And today, Professor Aulia will deliver a very important plenary lecture on equitable vaccine access and uptake, reaching the last mile in island and remote setting. We would kindly invite Professor Aulia to join us at the stage to deliver his speech. The stage is yours, Professor.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera buat semuanya. Good morning, ladies and gentlemen. I'm back. So first, thank to the organizing committee for inviting me to be here. At this occasion, I'm going to deliver talk entitled Equitable Vaccine Access and Uptake, Reaching the Last Mile in Island and Remote Setting. And I'm going to use the COVID-19 pandemic as the reference case. Okay. Yeah, so I have no potential conflict of interest to report. And then this is the outline of my today's presentation. So I'm going to start on COVID-19 pandemic mitigation scenarios, and then I'm going to talk about impact of pandemic on immunization performance, vaccine access challenges, and then a case study of a new vaccine introduction. Yeah. So, there is a report from World Bank published in 2017, identify the global distribution of epidemic preparedness in the world, including in Indonesia. At that time, the report highlighted the preparedness of our country if we face the next epidemic or pandemic. And then if you see from this figure, our score was not quite good. Because if you see from the quintile, we are in the third quintile, which is not quietly good in scale of 1 until 5. One of our weakness point at that time, in terms of healthcare facilities, in terms of healthcare professional readiness, if we face the next pandemic or the next epidemic, the country will not be ready. Yeah. And then if we are talking about the mitigation scenarios for any pandemic or any health crisis, in general, there are 3 mitigation scenarios. The first one is how to curtail interaction between infected and uninfected populations. So it is more likely a non-pharmacological intervention. So the stakeholders should encourage patient isolation, quarantine, social distancing practices, and school closures. And then the second mitigation scenario is how to reduce infectiousness of symptomatic patients. What we can do, we can practice infection control, antiviral and antibiotic treatment. And then The last thing is about how to reduce susceptibility of uninfected individuals through vaccination. Yeah. At that time, if you still remember the situation at that time in the country, why the government did not consider total lockdown? Instead of total lockdown, the government consider to apply PSBB or PPKM with different level for each region or area. So at that time, the government collected evidence from many published studies, including one of our studies. So at that time, we developed compartment model, consider 4 compartments, as you can see here: susceptible, exposed, infectious, and recover. So we call it SHARE model. So that was for epidemiology model. And then we also expand this model not only for epidemiology model, but we also consider the costing model. So at the end, we would like to calculate which intervention in terms of non-pharmacological intervention, in terms of social distancing measure, which scenario will be best for the situation at that time. Yeah. So we approach social distancing measures by considering different level of infection in each region, and then the government should different approaches in that area. So we call that intervention social distancing measure continuously. And then the government had to re-evaluate every 2 weeks. And you can see here, if we compare social distancing measures for only 1 month, and then for 1 year, or for continuous approach, re-evaluated every 2 weeks, you can see here we will have a significant impact in terms of number of infection, hospitalization, and death for the scenario of social distancing measures continuously. Yeah. We calculated total pandemic cost. So yeah, you can see here the total cost for social distancing continuously will be the lowest. And then in terms of averted deaths, the result will be the highest. So in health economic perspective, we could consider that intervention will be cost-effective because the cost will be lower and the effectiveness will be higher compared to the comparator that we use. If you see from this table, total healthcare cost is much lower than indirect cost. So if you still remember the situation at that time, the government would cover all treatment costs, all healthcare costs. But indirect costs was much, much higher. And it was not covered by the government. Yeah. That's the general situation about how we mitigate the pandemic by using non-pharmacological information pharmacological intervention at the beginning. And now I'm going to bring you to show the impact of pandemic on immunization performance. Yeah. The baseline situation about immunization coverage at that time, if we divided the country into 2 parts, Java and non-Java, so the baseline before the COVID-19 pandemic, there was already significant difference in terms of coverage. So the coverage of immunization in Java was always higher than non-Java. And then when the pandemic came, it would give most significant impact to Java region, and then at the end it will give a significant impact in declining immunization coverage in the country. Yeah. We also conducted another study to investigate further about the significant difference between immunization program in Indonesia as the consequence of COVID-19 pandemic. So we took rural and urban area into account. So we evaluated the national immunization program itself, and we also evaluated the COVID-19 vaccination program. So We consider three significant factors as suggested by the WHO. So we consider access, utilization, and program workload. Yeah. So you can see here, the findings reveal that urban regions consistently exhibited significantly higher coverage and lower dropout rates for the national immunization program, not for the COVID-19 vaccine. Furthermore, urban areas display a significantly higher ratio of vaccinators to doses for these vaccines. Yeah. So considering those three factors, you can see here that there was a significant difference in terms of coverage, in terms of ratio of vaccinators per dose, and in terms of dropout by considering rural and urban area settings. Yeah, this is the spider web to highlight the overall performance considering those three variables for rural and urban. So in terms of accessibility, COVID-19 immunization achieved 100% coverage rate in rural setting and 86 until 87% in urban setting. Conversely, routine immunization consistently exhibited better accessibility in rural area. So that was the general situation about the coverage. And then talking about utilization rate, COVID-19 vaccination were found to be higher in rural areas compared to urban areas, with respective rates of 0.68 and 0.59. And however, routine immunization consistently favor in urban area. And the last thing, both rural and urban areas display consistent pattern regarding the workload associated with routine vaccination for both programs. Yeah. Now we are moving to vaccine access challenges in an archipelago country. So, yeah. This is the illustration how vaccination can be considered the most beneficial public health program in the world, not only in Indonesia. So there was a study conducted by GHI of the Vaccine Alliance. They compare immunization with other public programs, not only healthcare programs, but with many public programs. They compare immunization with preschool education, public infrastructure, community health workers, government bond, and cardiovascular disease research. And you can see here the cost-benefit ratio from immunization is the best. So every $1 that the government or the stakeholder spend, it will bring benefit 6 times higher. And then talking about COVID-19 vaccination, at that time, there were many studies, and we can see here some conclusion about cost effectiveness of COVID-19 vaccination in low and middle income countries, given limited resources in those countries. Although COVID-19 vaccination in low and middle income countries is cost effective, increasing coverage in these countries would prevent millions more infection and save millions of additional lives. Yeah. What we can learn from the economic evaluation of COVID-19 vaccination, and how can we reflect the situation for remote area or remote setting? Yeah. COVID-19 vaccinations is a cost-effective or cost-effective intervention to mitigate pandemic. But COVID-19 vaccine availability is very critical. Infection incidence, vaccine price, vaccination cost, and vaccine efficacy are the most influential parameters impacting the cost-effectiveness value. Yeah. There is one study from Indonesia. The authors focus in West Java province. So maybe to give you a bit strong background about this study. So you already may know that the population of West Java contributed to 1/4 or around 25% of general population in the country. So we have a joke in the government or in the central government level. If we can give solution to West Java population in terms of healthcare problems, so we can solve 25% solution in the country. So yeah, this is the study about targeted vaccine infection could increase the COVID-19 vaccine benefits in Indonesia. So they consider several scenarios, fairly distributed, meaning that we have to consider level of infection in each area, and then compare to focus on five cities or 5 districts, because that's the easiest access to distribute, or 8 cities. And you can see here the result. In terms of number of active cases, the result will be most favorable if we consider distributing vaccine fairly by considering level of infection. No matter what urban or rural, no matter what remote or non-remote area. I want to bring you to see the illustration in the country about, this is very interesting article published by WHO Indonesia. A family affair, traversing the seas to bring vital immunizations to island. So there is a short story about Rahmi. She is a midwife from Pangkep, Indonesia. Was young, she used to wonder why her mother was also midwife, was always going away. Now I understand. She was fighting for us, her children, and also serving the island community where her skills were desperately needed. At the time, her mother, she had to provide care to remote island communities, places that could take her up to 24 hours to reach by boat if the weather and flores she operated. As the only healthcare worker on the island, her mother had to do it all: deliver babies, conduct health screenings and health promotion activities, and ensure everyone in the community was up to date on their immunization. Yeah. We have more than 17,000 islands in the country, and many people face challenges to access sufficient medical care, including routine immunization. And as its consequence, the risk of vaccine-preventable disease in the country is potentially high. Yeah. Because some islands are small and remote, it is difficult for each one to have a dedicated immunization center or clinic. Without an immunization center, some islands lack the ice or refrigeration needed to keep vaccine cold. So that's the illustration how the biggest challenge that remote islands have to deal with refrigeration and about supply chain issues. Yeah. So reaching all children with immunization, the government has been intensifying several efforts to address the decline in immunization rates caused by the pandemic. So we focus on reaching un- and under-vaccinated children, particularly in remote and underserved area. The pandemic caused significant disruptions to routine immunization service in the country. Yeah. And then this is the official statement from the Director of Immunization Services in the Ministry of Health. Every child, no matter where they live, has the right to immunization to protect them from life-threatening diseases. Together, let's ensure no child is left behind, because every dose matters. Every dose matters, and every child counts. So we have implemented several comprehensive strategies in the country. So we just launched a new electronic immunization registry that can be accessed in all healthcare facilities in the country. And then to catch up on missed vaccination, 3 rounds of nationwide periodic intensification of routine immunization have been conducted. We also provide technical assistance to strengthen priority provinces, including remote regions. Yeah. There is another study to describe inequalities in immunization coverage in Indonesia. Yeah. So complete immunization status was significantly associated with region and proportion of primary healthcare centers. So this is very in line with the previous slide, that we have a big challenge in terms of how to distribute vaccine in remote regions. Yeah, because those two factors are region and proportion of primary healthcare centers. There is a need to increase healthcare centers in each community with the objective to reduce disparities in maternal and child health services. Yeah. Now I'm going to show you a case study of new vaccine introduction, and we can see through this study how's the impact of selecting new vaccines to different regions. So we developed, in collaboration with WHO Global, we developed a tool, namely Total System Effectiveness. So this is to make setting priorities in terms of new vaccine selection in low and middle income countries. So we consider several variables: health impact, equity and financial protection, coverage, cost and human resources, vaccine administration cost, and vaccine procurement. Yeah. So we use rotavirus vaccine at that time as the reference case. At that time, there were 5 rotavirus vaccines available with different features or different effectiveness and other variables or parameters. So which vaccine should be used at the national level and remote area? So we compare the decision making should be made in the national level, and the decision making should be made in a remote area. And we use Nusa Tenggara Timur as an example. So you can see here, in the national level, we should consider vaccine number 3, and then followed by 4, 2, 1, and 5. But the rank, or in terms of product selection, the result will be different for remote area. And the result also will be different in terms of vaccine selection when we consider provinces' health service pattern. So yeah, this is the illustration how distribution in patient visits, specifically for primary, secondary, and tertiary healthcare center, will give different impact in terms of vaccine selection. Yeah, this is my last slide. Key takeaways. The pandemic had a significant impact on the immunization performance in urban and rural settings in the country. As an archipelago country, we face challenges accessing sufficient medical care, including routine immunization. And as a result, the risk of vaccine-preventable disease is high. There is a wide range of inequality in immunization throughout the region due to socioeconomic and demographic factors. And as we see from the Total System Effectiveness tool, it highlighted that different settings with unique geographic challenges will impact the vaccine selection. Thank you very much.
Thank you, Professor Olia. We kindly invite you to sit with us. The equity lens that you offer is very crucial. The personal accounts that you share, the anecdotal, which is not anecdotal, because something that we still observe every day, that health workers do need to travel by boat far distance just to reach the very community that they serve. So that's very relevant to us. Thank you. For our next speaker, we are very honored to have Dr. Kian Jin Lim with us. Dr. Kian Jin Lim is a neonatologist and an active lecturer and board member of the Indonesian Diaspora Global Network Health, and was an associate professor at Radboud University Medical Center in the Netherlands. Dr. Lim has over 3 decades of experience in pediatrics and neonatology and has authored over 100 international publications and delivered more than 300 presentations across Europe and Asia, and is the honorary appointed officer in the Order of Orange Nassau by King Willem Alexander of the Netherlands. Today, Dr. Lim will deliver a plenary lecture on developmental origins of health and disease, implication and dilemma for early life stunting. Please welcome Dr. Lim to the stage.
Thank you, Dr. Mutia. I would like to thank the organization to invite me to be here as a guest speaker. I'm feeling very honored because, as you know, I'm an Indonesian diaspora. It is for me an honor to give some presentation here. I'm maybe an odd duck in this company because I'm a clinician, not a public health expert. But I will discuss the consequences of early life stunting to the future of the public health. As you know, stunting is a major public health problems worldwide. And the global prevalence is about 22.3%. But the good news is the prevalence is still decreasing in the last 30 years. But the prevalence is still high in the low and middle income countries like Indonesia. Dit is de graphic from WHO. I can use the pointer there. The middle red line is the declining of prevalence worldwide, but the upper line is the prevalence in the Southeast Asia. It is still decreasing in the last 30 years. Dit is the prevalence of stunting in Indonesia. It is also still decreasing, and in the last 10 years it has been reduced for about 50%. It's quite good work from Indonesia. The most important risk factors for stunting is the blue one. That is the small for gestational age, babies with small gestational age, and baby which is born preterm. I will focus to this group, not the other groups. According to the new paradigm about developmental origins of health and disease, babies who are born with small gestational age, usually because they have intrauterine growth retardation, and babies who are born preterm, they will have long-term consequences for the future health when they become an adult. This theory is from Professor Parker, an epidemiologist from UK. He has launched his hypothesis in 1992, it's long ago, and originally he called it fetal and infant's origin of adult disease. His hypothesis is based on population study in a district Hertfordshire in UK, from the children who are born were born in 1911 and 1930 in UK. They have followed these children until their death, and his research has found that prevalence of metabolic syndrome is negative correlated with birth weight. For example, a baby with a birth weight of 2.5 kilogram has 18 times higher incidence of metabolic syndrome as compared to baby with a normal birth weight about 4.3 kilogram. As you know, a baby of 2.5 kilogram who are born in 1911 they are not a preterm baby because at that time neonatal intensive care unit doesn't exist. Because babies who are born preterm in that time, they are usually dead. So a baby with birth weight of 2.5 kilogram are baby with small for gestational age, plus a term baby with intrauterine growth retardation. So he came to his conclusion that undernutrition in the womb will result in the so-called fetal programming for these children to get a worse health condition at adult life. This is this hypothesis. Malnutrition at different ages, at different stages of pregnancy and infant can lead to an increased risk of metabolic syndrome. It consists of obesity, high blood pressure, high triglycerides, low HDL cholesterol, resulting in cardiovascular disease, and also insulin resistant with diabetes type 2. Again, the schematic presentation of this hypothesis is undernutrition will lead to low birth weight, and it will result in increased risk of illness in adulthood. These are many diseases who are attributed to developmental origins theory of hypothesis of Professor Parker. Diabetes mellitus, obesity, dyslipidemia, hypertension, coronary artery disease. They are the components of metabolic syndrome. But stunting at early life will also result in stroke, in kidney and liver failure, immune dysfunction, Alzheimer's disease, and also some psychiatric diseases like depression, bipolar, and schizophrenia, and also for cancer. In the beginning, many doctors didn't believe this hypothesis of Professor Parker, but he got support, and the first support is also from the Netherlands, and also from the famine in China and in Leningrad in Russia. This is the period of Dutch famine. You can imagine that in the Netherlands in 1945, that the people of Netherlands have suffered from famine if you look at the Netherlands at this moment. At the end of the World War II, because during World War II, Netherlands was occupied by the Germans. In order to make Netherlands free, the Dutch people has made a strike in the railway, so the transport of food from Europe to the Netherlands has been blocked, and so in the period at the end of 1944 till the liberation of the Netherlands, the people, especially in the west of the Netherlands, has suffered from lack of food, and famine, and also a lack of energy. So they suffered severe hunger. And the women who are pregnant was the subject of this study. The study has studied the health of the babies of the women who have suffered hunger in this period. Especially is interesting when the mother has suffered from hunger from the beginning of the pregnancy. This is the result of the study. When the mother has suffered hunger at the beginning of the pregnancy, the babies will get the same as what Professor Parker has supposed. That is the metabolic syndrome, glucose intolerance, atherogenic lipid profile, obesity, stress sensitivity, coronary heart disease, and also breast cancer for the girls. This is the results of the famine study in China. During the Cultural Revolution, some area in China has also suffered from hunger, and that is only a part of this study. As you see in the left graphic, in severely affected areas, that the children who are exposed to the hunger in intrauterine, dus the second bar, they will also have a higher incidence of metabolic syndrome. But they have looked up to the dietary pattern of the families, and especially the families with dietary pattern using Western food. The chance to get metabolic syndrome is much higher than the children who has a dietary pattern of traditional Chinese food. Dus maybe the Western diet will increase the risk of metabolic syndrome. The third famine study is from Leningrad, also from the Second World War. People in Leningrad doesn't get enough food to in that period. But the duration of the famine in Leningrad is much longer. It's about 2 years. However, the result of the study of the Leningrad famine, they have shown that no direct effect of the prevalence of cardiovascular disease and risk factors after 7 decades since exposure. That is completely different from the study from the Netherlands and from China. There is some discussion why is there any difference, but maybe is that the problem. As I've said, the famine duration in the Netherlands is about 5 months. In Leningrad is more than 2 years. And the population of the Netherlands was well nourished before the famine, but the population of Leningrad was undernourished before the famine. And the babies of the Dutch famine, after the liberation of the Netherlands, they will grow. They will get normal feeding, normal food, so they have the ability to make a catch-up growth. Yeah. But the babies of Leningrad who suffered hunger intrauterine doesn't have any possibility to make a catch-up growth because the famine is still persisting. Therefore, maybe the catch-up growth is a more important factor than undernutrition intrauterine to get the metabolic syndrome in the later life. There are many data about the influence of catch-up growth to the health in adult life. For example, there is a study from Sweden, that death from coronary heart disease may be a consequence of poor prenatal nutrition followed by improved postnatal nutrition, catch-up growth. As you see in the graphic there at the left up, that the hazard ratio for low birth weight in combination with catch-up growth is much higher than the normal baby without catch-up growth. There is another systematic review from China, and the conclusion is that accelerated weight gain at infancy among preterm children may be a critical contributor to obesity in a later life. This is also a very interesting animal experience from Professor Barker himself. in mice with normal protein intake during pregnancy and normal protein intake during lactation, and they compared with mice with lowered protein intake during pregnancy, and then after the pregnancy they will get a normal diet. So you can see that the average age is reduced for mice with intrauterine growth retardation and after the birth with normal food intake. It is also another systematic review which says that the results support rapid postnatal catch-up growth of low birth weight infants as a more important factor for cardiovascular disease in compared to low birth weight alone. And this is also another review article with key message that some evidence supports the view that early life catch-up growth compared to no catch-up growth following low birth weight is beneficial for the short term, beneficial to survive the lack of nutrition, but harmful in the long term. How can be explained, and that is the explanation of Professor Parker. He called it the thrifty phenotype hypothesis. Yeah. During fetal undernutrition, yeah, there will less glucose available for the fetus, and it will result in less insulin secretion and increased insulin resistance. Yeah. So that more glucose is available for the more vital organs. This is no problem when the undernutrition still persisting, but after normalization of the nutrition after excessive food intake, after the undernutrition, the glucose tolerance of the changes in the insulin secretion is still persisting. So it will result in glucose intolerance, and it will result to diabetes mellitus type 2. Probably we have to do with two hits phenomenon. Yeah? The first hit is the intrauterine undernutrition, and the second hit is the catch-up growth, the normalization of nutrition or an overnutrition after stunting. It is the picture. On the left side is the Dutch famine. You can see people has to wait for getting food at that time, and the other picture is the boy who are very thin. Yeah. But after the liberation of the Netherlands, there are more than enough food. If we go to the supermarket at that moment, everyone come out with a very full box with all kind of feeding, and most children got too much feeding; they cannot eat all the feeding, and it will result to the metabolic syndrome. But it gives dilemmas also for us as clinicians. As doctor, you have learned in the medical faculty after an intrauterine growth retardation, we have to give so much food and calories to the babies that they will make a catch-up growth. So I have also learned during my training as pediatrician. But according to the data I have presented, maybe is it not wise to give this baby with intrauterine stunting, to give them so much nutrition to make a catch-up growth. For example, a baby is born at the -2 SD birth weight. Usually, we have learned to make a catch-up growth as the red line, so that the growth line will come to the null SD. Maybe is that not wise? maybe is that better to keep this baby at his own growth line at minus 2 SD. I don't know, but I think it is better than to bring this baby catch-up growth. The consequences of the Barker hypothesis is also more for the future. Yeah? It will result in more disease in the future, and it is a vicious circle. Yeah? The children who survive the famine, if they become adult and have children, their children will also make a higher chance to get metabolic syndrome in adult life. So we will create a more unhealthy population. That is a problem for the public health. This is one of the most, the latest slide for me. As you see, yeah, the preterm baby of SGA baby, in the childhood, they will a tendency to get obese, and as adult also they will get obesity, diabetes type 2, and hypertension, especially the women. When they become pregnant, the pregnancy will be complicated by hypertension, by diabetes type 2. It will result in a preterm baby, and the preterm baby, when they become adult, will also get the metabolic syndrome. So that is a vicious circle. How to prevent it, that is still not clear what you have to do, but I think in generally speaking, you have to have a healthy lifestyle, especially during preconception, not only during the pregnancy, but during the preconception, and no smoking during pregnancy, optimal body weight, and in the child age, also healthy food for the children, lots of exercise, and maybe more preference for traditional food than the Western food. Yeah? I think Indonesia has a rich history for traditional food, and then especially we have to prevent catch-up growth, I think, yeah? And reduction of stress. It is the summary, but I think because the time I'm not reading, call it all at all. Thank you for your attention.
Dr. Lim, would you kindly be seated with us? Thank you, Dr. Lim. It's a very important and relevant lecture to the context of West Nusa Tenggara, where stunting is prevalent, steadily prevalent. So thank you to our speaker, Dr. Lim. And then we have our third speaker, Professor Ernesto Gregorio Jr. Professor Ernesto Gregorio Jr. is a chair in the Department of Health Promotion and Education, College of Public Health, University of the Philippines, Manila, with a vast expertise in health promotion, school health, governance, and mental health literacy, and has led more than 20 WHO-supported projects across the Western Pacific region. This morning, Professor Gregorio will deliver his lecture on integrated approaches to tropical diseases, enhancing local response capacity. Joining us virtually from Manila, we're very pleased to have Professor Ernesto Gregorio, which I believe is often called as Professor Jun Gregorio.
Yeah.
Professor Gregorio? Yes. Can you hear us well?
Yeah, I can hear you, and thank you. Can I be allowed to share my slide, please?
Yes, yes, please. Wonderful. We're honored to have you with us. Please have a go with your presentation.
Okay. Let me know if you can see the slide.
Yes, we can see the slide.
Okay, thank you very much. So first, good morning to everyone. I wish I were there. No, I would have wanted to be there physically, but my current workload did not allow me to live because there are ongoing classes. But I think this is good enough to share with you a presentation entitled Integrated Approaches to Tropical Diseases, enhancing local capacities. No? So this was the topic assigned to me, and I would be glad to share with you my experience and knowledge about these approaches. So as mentioned, I'm Dr. Gregorio. I'm with the Department of Health Promotion. So what I bring are my experience as a teacher, as a faculty, as a researcher, and also as someone who provides training for local chief executive on health leadership and governance, because I also coordinate the so-called Dr. Steven Zuelik program on health leadership and governance. And I will be sharing with you a case study on how we use leadership in enhancing local response towards the end of my presentation. But so good morning, everyone. Good morning to all the officials present there and the guests present physically, and also those who are present online. So this is going to be the outline of my presentation. I will be talking about briefly about the Philippine health system and a few data on burden of diseases, on selected tropical diseases in the Philippines, so that this will provide the context of my lecture. And then I will be sharing with you some of the integrated strategy that addresses tropical diseases like rabies and dengue. For rabies, it's what we call as the One Health approach. And then I'm excited to share with you some of the application of this strategy in selected tropical diseases. One is about the research that my student did and a project implemented also by my students. So basically, I'm going to share with you what I did as a trainer and also as a faculty that develop students, Master of Public Health students, and other helpers. You can see that the Philippines is one of the Southeast Asian countries. This data is 109 million. So Indonesia has more, but we also have increasing population. In fact, teenage pregnancy in the Philippines is also on the rise. No. So we have, our country is divided into regions. So there are 18 regions. And then we have 1,493 municipalities all over the country. And there is only one lone town in the national capital region. So those are the situation. I am sharing this because I want you to understand that the Philippine health system in the Philippines is decentralized, meaning to say that the power, the authority is actually under the local government officials. Okay? So as I mentioned, we have a decentralized health system, and the Department of Health, which is a national government agency, is the one mandated to provide health services and public health interventions. No? So they are there at the central office, policy development, regulation, standard setting, they are responsible for that. And then because of our geographic distribution, we have the so-called, as I mentioned, regional offices. There are 17 regional offices. There's additional one, so it should be 18. Regional offices all over the country. And these regional offices will be responsible to provide technical assistance to each local government, either at the provincial, city, or municipality. So we have 3 different, or maybe 4 different types of local government in the Philippines. The biggest will be the province, which is headed by the governor. And then each province would have its city and several municipalities. No? Each city or each municipality is led by a city mayor or municipal mayor. And then at the lowest level, the lowest unit in the Philippine governance level are the villages, or what we call as barangays in the Philippines. And they also have their own governance structure there. And the highest is the village captain or the village chief. We call it barangay captain. So you can see there, the different regional offices in the map. So like we have, we use terminologies like, for example, you see on the green, Mimaropa, that is a combination of the first few letters of the province. For example, Mimaropa would mean Mindoro, Marinduque, Romblon, and Palawan. So there are 4 provinces per region. So that's how our health system is organized in the Philippines. Okay. So I was tasked to talk about tropical diseases, although Philippines is facing, just like Indonesia, multiple burden of diseases. And we also take a big burden related to tropical diseases. So there are a lot, no? There are a lot. There are some caused by bacteria, some caused by virus, and other are called vector-borne, and we also have zoonotic. So the ones, there are so many tropical diseases in the Philippines, but in the interest of time, I will only focus in sharing with you the current burden that we have on those written in reds, no? So I tried to download the burden of disease. I only focus on deaths in the interest of time. I used the Institute of Health Metrics and Evaluation, the Global Burden of Disease 2023. I tried to look. So this is just new because in the Philippines, we had made an arrangement with the Global Burden of Disease that we can see the provincial data. So we subnational data specifically on the provinces, whereas the other countries only have up to the regional level. So in the Philippines, we can see the data down at the provincial level. So I tried to look at the burden of tropical diseases like tuberculosis. And, we have a big problem of tuberculosis. And I look at the data and I just presented the top 10 provinces with the greatest burden in terms of death, no? So you can see that Negros Occidental, this is a province in the middle of the country, in the Visayas region. It has the highest death rate, no? Which is 35.41 deaths per 100,000, and then the lowest among the 10, no? Of course, we have data from the more than 10, but I only focus on the 10 provinces. And the Occidental Mindoro, this time another province in the north, it has 28.63 deaths. So it's high, no? If you compare it to the national data on deaths in the Philippines related to tuberculosis. This is only tuberculosis, both sexes and all ages. It's 20.16. So Negros Occidental and Occidental Mindoro, so they are in the top 10 leading causes of death related to tuberculosis. In terms of malaria, we are able to have a lot of improvement in terms of our malaria data. So there are only very few provinces in the Philippines that has endemic problem on malaria. So provinces that are still endemic for malaria. And Palawan is the highest, no? 0.82 deaths. If you compare it to the national data, it's much, much higher. So Palawan, it's one of the beautiful islands in the Philippines. Mimaropa, Pa is Palawan. So it has a lot of beaches, but in the mountainous areas, it's still a lot of problem in terms of malaria. We have Vivax and Falciparum as endemic species. Okay. So in terms of dengue has been always a problem in the Philippines, but you can see that we have spikes sometime after 2010, and then but you can see a downward trend in 2022, no? So, and you can see that I also look at the top 10 provinces that have high dengue deaths. And I noticed that Davao de Oro, this is a province where the governor used to be a former graduate of our program. You can they still suffer on dengue, so 1.94 deaths per 100,000. And of the 10, the lowest is Batangas. No? So dengue is present every month. There is no seasonal appearance of dengue anymore in the Philippines. We often have problems related to dengue. And then for schistosomiasis, one of the tropical diseases that's still present in the Philippines, the problem is highest, the deaths, in terms of deaths, in Western Samar. This is a province in the Philippines, in the middle of the country. And then Davao del Norte, Mindanao area, south of the Philippines, they also have deaths related to schistosomiasis. And of course, because schistosomiasis is only endemic in certain areas of the country, then the national figure is much, much lower compared to the Western Samar and Davao. In terms of rabies, we have increasing cases of rabies and then in the recent years, increased dog bites and rabies also. So I also checked that the data. I reviewed the 10 leading provinces in terms of rabies deaths. So Davao has been consistently in the top list of provinces with problems related to death related to tropical diseases. So 0.87 deaths, and then Camarines Sur in Bicol, South Luzon, 0.50. And of course, if you compare it to the national data, they are much higher than the national figure. Okay. So those are the different burdens of selected tropical diseases in the Philippines. And of course, the Department of Health as a lead agency is responsible for the provision of policy. They craft policies, regulatory standards, licensing requirements, etc. And they provide technical assistance to the local government unit. But really, because of the decentralized health systems in the Philippines, the bulk of the response is actually under the responsibility of the local government unit. And whenever I train local chief executives on health leadership and governance, I train mayors, we train governors and municipal health officers, provincial health officers, and other health officials of the Department of Health. I always emphasize these determinants of health, no? Because this will give you a picture of how should a response or plan be made, no? You have to understand, we make sure that they understand this, that health are, solving the problem, the health problem is not only the responsibility of the Ministry of Health, because of the influence of other factors that are beyond health. Those are non-medical, and we call it, the WHO calls it social determinants of health. So if you focus on the lower part, which is 20%, you are only addressing problems related to access to services, access to care, and providing quality of care. So it's okay, we should do that. But if you focus on that, you are only contributing the 20% of the response. And then if you move up, you will see that 30% of why people get sick, particularly tropical diseases, is because of their health behaviors. The behavior of the people that put them at risk to different tropical diseases. And then if you move up a bit higher, then you will see that the environment plays a big role. The physical environment in the reason why people get sick. No, if you have an environment that is conducive to proliferation of dengue vector, mosquito or malaria, then it will contribute to the higher burden of vector-borne diseases. And the biggest part of why people get sick is related to 40%, the social determinants of health. So these are those that are related to education, income, job status, family relationship, social support and relationship, community safety, and you see that these are not actually health. So there are other government agencies which are responsible to provide this education, income. So, but they contribute 40% to why people get sick. So, therefore, the response to any health problem should be integrated and should take into consideration the different groups of factors present here. So we borrowed this from the Institute for Clinical System Improvement. It's very, very, very important diagram to show the role of social determinants of health. Okay, so basically that's our burden and our framework that we follow in our response. I will share with you some bits and pieces of output of our students. I'm very proud of these students, so I want to share with you. For example, I just finished advising one MPH student, a medical doctor who studied MPH in our college, and her paper is on rabies, dog bites and rabies. And one of the outputs of her thesis is this one. No, this has been accepted for publication in a local journal in the Philippines. The title is Acceptability of One Health as an Approach in the Prevention and Control of Animal Bites and Rabies. Because the integrated approach is very much can be observed in the rabies prevention and control program. No? Because there is an intersectionality between the different government agencies like DOH, the Department of Agriculture, which is responsible for animal health. And then, of course, you have the local government unit, which is responsible for implementing the local response. So we use qualitative grounded theory approach sometime in last year, and we implemented the study in one municipality south of Luzon, in South Luzon, where that municipality has reported 4 deaths related to rabies and an increasing animal bites from 406 to 624 in 2022. So we use key informant interviews, interviewing people involved in the National Rabies Prevention and Control Program of the DOH, and how we basically asked them on how they implemented the national program down to the local level. So we have representatives from the province, municipality, and down at the local level, barangay level. So this is just part of the results. No, it's a long study. It's a long result. So I will be sharing with you a bit, just one part of it. No. So we were able to identify this particular team that there's current multi-sectoral coordination, helps program implementation, but faces operational gaps. So it highlights the importance of intersectoral collaboration, coordination, integration of different strategies in the response related to rabies. No, and then there were several sub-teams. I will not discuss the detail of it, but the sub-teams that we were able to identify is that improvement of functional intersectoral committees to promote joint action. So at the local level, they formed intersectoral committees that are represented by different agencies. The sub-team 2, we found that there is limited awareness of the One Health approach because the framing that we use is One Health. This is quite new in the Philippines. And of course, the people there, they have limited awareness about the One Health approach. And then they also admitted that they have insufficient training and capacity building on the One Health approach. And because of the result of this study, we were able to identify training needs that the local government and the Department of Health can provide in terms of One Health. Okay. And then part of the result of the study is to review the conceptual framework for One Health by integrating another theory, which is the health belief model. So we tried to integrate the health belief model to highlight the demand side of the problem related to rabies. So we look at the health beliefs, the barriers, the different components of the health belief models, including sociocultural determinants, social support, and look at how they are integrated into the One Health approach that combines human health, animal health, and care for the environment. Okay, so that's the session. That's the my input for rabies. No, so for dengue, the different local government units, because they are autonomous, they can actually implement their own integrated vector control programs. No, they have the resources, they have the capacities, and they have the freedom and autonomy to implement what they want based on the needs of the local government. No, but the National Department of Health, they have this National AIDS Born Viral Diseases Prevention and Control Program that aims to have an AIDS-borne viral diseases free Philippines, and the goal is to reduce the disease burden of dengue and to contain and prevent transmission of two other tropical diseases present in the Philippines in the past, no? Chikungunya and Zika, but now we don't have much cases of chikungunya and Zika. So it basically provides the local government the strategies that they can implement, like early detection and treatment, surveillance, integrated vector management, health promotion and education, monitoring and evaluation, management, and including research and development. So basically, this is what we do in the Philippines, integrated approach as far as the AIDS vector-borne diseases are concerned. No. So the second case study I'm also proud to share is actually an output of our students deployed in one province in the Philippines. No, we have a new program in our college which is what we call MDMPH. So this is a dual degree program where the students would graduate with 2 degrees after completion. So we tried to intersperse the field practice public health courses inside the medical curriculum, but at the end of towards their fourth maybe fifth year they are fielded, they are sent to the different municipalities in the Philippines where they are supposed to do a situation analysis and then come up with a project that will address the priority health problem of the municipality. So I'd like to recognize 2 students here. Later on, I will, in my next slide, they have their names. So basically, they did a situation analysis looking at the leading causes of morbidity and mortality, talking to the people, discussing, doing focus group discussions, key informant interview, talking to the local officials on what will be what are the leading causes of problem, and then prioritize that. So based on the situation analysis, they identified a lot of issues, and I heard nutrition problem earlier. So this is also one of the big problem in the Philippines, nutrition. But there are a lot of interventions now on nutrition. So the group decided to focus on tuberculosis. So this is local response, no? So after doing the prioritization, they were able to identify high incidence of tuberculosis as their priority project. So they designed a project to address the high incidence of tuberculosis. But the problem of tuberculosis in the Philippines, in that area of the Philippines, is that they also have another tropical disease, which is paragoniamiasis. And paragoniamiasis, as you know, is a fluke. It's a parasite that mimics tuberculosis. The symptoms of paragoniamiasis is basically like tuberculosis. So, and therefore, people there are being treated for tuberculosis when, in fact, they don't have TB, but they have paragoniamiasis. So, they would report it as multi-drug resistance in some cases because they don't respond. Of course, parasite don't respond to the treatment for
Professor
tuberculosis.
Gregorio, we truly am sorry. We only have 1 minute left.
Okay, yeah, I'll just finish this
Yeah,
part
thank you
and
so
then
much.
I'll
Thank
skip.
you.
Yeah. Okay, so the paragoniamiasis there is included in so this is what they wanted to do, establish to institutionalize an integrated TB paragoniamiasis detection and surveillance system, and they did some partnership building with academe. So the local, this is not UP, but local higher education institution, they partner with them. They facilitated the partnership between the local government and the academe to respond to the problem of tuberculosis. So they came up with memorandum of agreement, alignment meeting with provincial health office staff, consultation with local government, and then they also provided training for the village health workers on how to detect tuberculosis, paragoniomyces, and how to educate people about the problem. They also did some advocacy work, like presenting their project to the local policymakers so that they can enact policy ordinances that will provide direction and funds to the program. They also facilitated the development of socio-behavioral change communication material on tuberculosis and paragoniomyces. And then they also developed a village health pocket field guide manual. So that is, and then, but the most important thing here, this is the end of my presentation. Parallel testing, integrated response is important in TB control because you also can address the problem related to another tropical disease, paragoniomyces. So the core innovation of the ordinance is the institutionalization of parallel testing. So what happens now is that when a patient is diagnosed for tuberculosis, on top of the acid fast testing, they also, this is my last slide, they will also include testing for paragoniomyces so that they will be able to detect the presence of two diseases. So thank you very much. So that ends my presentation.
Thank you so much. Thank you, Professor Gregorio. It's always great to see your great work. And now we're moving on to our fourth speaker, Dr. Henry Surendra. He's an associate professor and coordinator of the Master of Public Health program at Monash University in Indonesia, and fellow of the Royal Society of Public Health and honorary fellow at the Menzies School of Health Research. And the title of Dr. Henry's talk this morning is Advancing Malaria Control Through Improved Surveillance, Diagnostic and Risk Mapping. Dr. Henry, thank you for being with us on Zoom this morning. Can you hear us clearly?
Yeah, sure. Thank you. Thank you very much.
Delighted to welcome you.
Sure. Good morning, everyone. Thank you very much. It's really, really great to be here with you today with some outstanding speakers. I really enjoy the talk from previous speakers. So today I'm going to be sharing a bit about how our work is trying to advance malaria control through improved surveillance, diagnostic, and also risk mapping in Indonesia. Here are the outlines of my presentations. I'll start with giving a bit of background around malaria, why it is still important public health issues globally. So, according to the latest WHO malaria report, we know that only 53% of countries already certified for malaria-free by the WHO as of December 2024, meaning that close to half of total countries are still struggling to eliminate malaria from their areas. We also know from similar reports that 263 million new cases and also close to 600,000 deaths reported in 2023, which again highlights how important it is to to improve control and elimination efforts for malaria. What about malaria in Indonesia? As you know, Indonesia has now moved from Southeast Asia regions of the WHO to Western Pacific region, but according to the latest report from the WHO, Indonesia actually accounts for close to 30% of malaria cases in Southeast Asia region, just below India. In fact, the report also suggested, like from 2015 to 2023, there basically no significant difference in case incidence, meaning that there is no significant decline in terms of burdens of malaria. In fact, there is an increase in mortality rates for malaria by around 6%. Moreover, the report also suggested that there is an increasing trend in number of zoonotic penile malaria cases in Indonesia. As you know, this zoonotic malaria is emerging issues in Southeast Asia, including in Indonesia. This is a bit different to the human malaria, where the transmission is facilitated by the mosquitoes from human to human, but in this case, the mosquito will bite infected monkey, and then they will transmit the parasite to human. And then why surveillance is important? According to the WHO Global Technical Strategy for Malaria Elimination, transforming malaria surveillance into a core intervention is essential if we want to achieve goals of eliminating malaria by 2030. Surveillance particularly becomes more important and at the same time also more challenging as transmission declines, meaning that in areas where the transmission is becoming low or close to zero, there is a need for more frequent and more intense reporting, which is close to real-time reporting. Because why it is the case? Because of course, in very low areas of malaria where the cases are close to zero, we need to be able to find the cases as soon as possible, diagnose them, treat them, report them to the surveillance system, and then act based on that to prevent further transmission. However, in many Southeast Asian settings, the surveillance becomes even more challenging because of few reasons, such as the fact that in Indonesia, for example, we do have multi-species infection, like, we do have falciparum, vivax malaria, ovale, and others, and also now penile. And these problems, combined with the difficulty of identifying where and in which population actually the residual transmission is still occurring. So, according to previous literature, specifically in Indonesia, we know that the lack of surveillance in malaria could actually lead to reintroduction and even outbreaks in areas entering elimination. One of our studies in elimination settings in Yogyakarta province actually found that the fact that the existing surveillance could not detect increase of malaria exposure prior to where the outbreaks occur in this study setting. We identified several contributing factors, such as diagnostic limitation, the fact that our surveillance is using RDT and microscopy, and then we do have diagnostic limitation for that. And then secondly, it's due to challenge of controlling Plasmodium vivax relapse cases. You know that vivax can be dormant, and then at some point of time they can be relapsed, and then can also introduce new transmission in the population. And lastly is due to surveillance limitation, partly related to operational constraints, such as health-seeking behavior, like health system capacity, and so on. In the next couple of slides, I will be talking about a challenge that our surveillance system are facing in terms of controlling and eliminating malaria in Indonesia. As we know that, many studies actually have suggested that our surveillance system can only detect a very, very low proportion of malaria-infected individuals, as you can see from my graphs here, partly because of the limitation of RDT and microscopy, which are two tools that are currently being used widely in Indonesia, and I think in other countries trying to eliminate malaria by 2030. We know that PCR is excellent because PCR can detect individuals with very low parasitemia, but it is not a standard diagnostic in the field. It's more being used in research settings. Now, a few studies actually, and also report from WHO, have suggested that the limit of detection for microscopy is closer to 100 to 200 parasites per microliter of blood, meaning that if someone gets infected and they only have parasites less than 100 microliter parasite per microliter in their blood, they will be likely not detected by microscopy. And reports also suggested that the sensitivity of microscopy then becoming even lower in area where transmission is already low and close to zero. Why is it the case? Because the lab technician, the microscopists doing the examination are not used to see malaria parasite in regularly basis because of the cases are very low. Therefore, they are no longer used to identify parasites by microscopy. In one of our studies, based on data from Timika, which is now in a manuscript is in preparation, we found that the sensitivity of microscopy is very low when we compare it with PCR, for example, in here, based on close to 2,500 samples. We found that the sensitivity is around 38% for falciparum and only 31% for Vivax compared to PCR. And then what does this mean for public health? It means that around 63% of falciparum and 70% of Vivax infection were not detected by our existing surveillance, in this case, based on microscopy. This means that because we are missing a high proportion of cases, these cases are then being, being circulating in community, in population. Therefore, they will be likely maintain the transmission in population because they are not captured by our surveillance system. And what about RDTs? You know that RDTs are being used in many settings in Indonesia, especially in remote areas of Indonesia where diagnostic is needed quickly in the field. We often use RDT because it is easy to use, right? Easy to carry to the field. But a study published in Nature in 2015 suggested that RDT will likely miss very large proportion of people that actually infected and can be confirmed by PCR, but not detected by RDTs. As you can see it here, as the prevalence getting lower, meaning that in areas that is really close to eliminating malaria, the proportion of people not detected by RDT are becoming very, very high. As you can see on my slide in here, the one that I circled, you can see that RDT will miss 94% of people, of adult people, and then 87% of teenage and kids, and then 76% of under 5 years old people, kids that are infected by malaria. And one study is testing the use of RDTs among pregnant women in Indonesia. I think this one is also in Papua, suggested very, very low sensitivity, but very good specificity, meaning that we cannot rely on the use of RDT to find cases, but probably we can use those RDT with very good specificity to rule out people who are not having malaria. Now, another challenge for surveillance is asymptomatic infection. You can see the graph on my right side of slides illustrating how some cases are clinical and then can be detected by microscopy or by RDTs, but then some large proportion of cases are asymptomatic but still detectable. But on the other hand, on the right side of my slide, you can see that, on my left side of my graph, you can see that there are a huge proportion of people that are both asymptomatic, meaning they don't feel anything, they have no symptoms, therefore they will not likely go to the health facility because they feel they are healthy. And then they are not detectable. The study suggested that 63% of people are asymptomatic and then negative by microscopy. This again means that these undetected people may or may not then become source of transmission in population. Now, in addition to diagnostic challenge, we also know that our surveillance also face some operational constraints such as knowledge, attitude, and practice of community and limited resources. For example, challenging migration surveillance because of high mobility, undocumented population, and so on. All of these I'll be discussing in the couple slides that I have prepared. For example, one of our studies in elimination setting in Kulon Progo in Yogyakarta found that our modeling found that there are heterogeneous probability of care seeking, meaning that some people may come to health facility, some other people will likely not to come to the health facility. And also we found that there's variability across health facility in terms of the availability of testing for malaria. We found that care seeking was higher at facility regularly providing anti-malarial drugs. We also found that the availability of functioning microscopy associated with increased odds of being tested for malaria. This suggests that some health facilities in malaria elimination settings do not actually have functioning microscopy, which then, improve undetectability of malaria cases in population. What in one of our other study in East Kalimantan in the IKN areas, the new capital city of Indonesia, we found that malaria infection in East Kalimantan, which is also close to elimination, are associated with overnight forest-related activities such as logging and watershed rehabilitation, and also highly associated with imported infection among migrant workers coming from malaria endemic setting. Because this is not surprising, because we know that the IKN project will, of course, will then result in a huge number of people, workers coming from outside Kalimantan to work on the IKN development. We also found that the surveillance and control program facing challenge related to undocumented workers. Some people come to the sites and do work, but then they are not officially documented, therefore cannot be traced by the surveillance system. Now, this graph is just to summarize the complexity of malaria surveillance. For the fact that we do have multiple species of Plasmodium, 5-fact cytnozoid challenges, emerging zoonotic malaria, and many other factors like climate and environmental changes, forest-related occupation, and also those operational challenges that I just discussed. Then we believe that there is essential need to improve surveillance and control for malaria if we want to eliminate malaria by 2030. Now, what we've done in terms of previous work that we've done to inform decision making for malaria elimination, we have done novel modeling studies in Indonesia where we use some modeling to basically estimate the probability of areas, in this case health facilities, to be able to detect zero malaria cases if they are truly zero. So we do those kind of modeling, and these models also recently being used in one of our studies, in multi-country studies that we published in Lancet Global Health. We also use similar approach, and the study suggested that the current WHO criteria for assessing malaria, like there is no local transmission in the consecutive 3 years, for example, and certain capacity that the surveillance have to be able to detect malaria cases in the population may not be sufficient to to actually confirm the probability of zero malaria transmission in the population. Now, we also do some ongoing work where we try to do some modeling of Earth observation data, where we collect satellite-derived data on climate and also environmental data across decades. And then we also collected data from active and passive surveillance. And then we tried to link those data to assess the potential impact of environmental and also climate changes throughout times on malaria transmission dynamics in our study settings. In addition to that, we also try to combine the use of novel multiplex serological diagnostic with satellite data and the advanced and novel modeling to estimate and predict risk of malaria in other vector-borne diseases in East Kalimantan. So this work is inspired by our previous work where we use the multiplex serological diagnostic tools to identify area at risk of malaria outbreaks in elimination settings in Java. So we are trying to use the similar diagnostic tools, and then we are trying to combine them with satellite data and some novel modeling approach to produce something more or less like now being shown on my right side of slide. So this was based on other projects assessing different diseases, but the idea of this ongoing project is actually to also produce risk map that will allow us to identify areas with potential risk of outbreaks in the future. Now, in terms of the ongoing process of our works, we try to build surveillance capacity in the field in East Kalimantan, where we train 4 lab technicians and 12 data collectors, which consists of nurses and public health officer. And we established 2 site labs there where we will be storing serological samples and where we will be processing some of the samples before then being transferred to our lab in Jakarta. We also train our staff in the fields to do not only samples collection, but also data collection using a tablet-based software that we previously validated in the Philippines, in fact, and also in Java. And we also train them to do GPS data collection of the household location of the people that we sample. So the idea is to collect complex data of GIS data and then health-seeking behavior data, risk factors data, and samples, and then we will be linking those data in the future to to better understand the transmission dynamics of malaria and other vector-borne diseases, and also to predict when and where outbreaks risk may occur in the future. To conclude my presentation, the key takeaways, I guess, from my talk will be, as advised by the WHO, transforming surveillance into core intervention is essential to achieve malaria elimination in the future. That we know that we should note that challenges in surveillance are complex and requiring improved disease surveillance capacity in terms of diagnostic, because we know we only use microscopy and RDT for now. And then in terms of risk mapping, where we can use more advanced technology to collect satellite data, GPS data, climate data, and so on, and then use novel modeling approach to better understand the risk in the future. We suggest that future research needs to address challenges related to diagnostic limitation, probably implementing molecular diagnostic also in the future to improve case findings, especially among those subclinical infection and asymptomatic infection, and some operational and implementation research, I think, to to assess operational and programmatic bottleneck, and also to improve the operational and programmatic performance in the field to better control and eliminate malaria in the future. If I still have time, these are just I have two more slides showing future work that we are trying to do, where we will be doing some flying drone. In fact, next week we are doing drone training in Papua, in Timika, where we'll be training district health officer to fly drone, use the picture taken from the drones to identify areas that are likely to become breeding sites for malaria vectors, for example, and then use this data, link them for disease modeling in the future. Another work that we are trying to do also in East Kalimantan is to monitor human movements, because we anticipate there will be massive human movements, both coming from outside the East Kalimantan and also within the East Kalimantan province itself. So what we are trying to do in the future is we are trying to do a longitudinal tracking of people or high risk group like forest loggers, for example, miners, where we will be equipping them with GPS trackers, and then we will try to track their movement and link those with environmental risk of malaria transmission. My last slides, I would like to acknowledge my huge partners and huge collaborators from OKU Indonesia, Oxford University Clinical Research Indonesia, NUS, the London School of Hygiene Tropical Medicine, Menzies in Australia, Universitas Sumatera Utara, and Wellcome Trust and University of Oxford for supporting the work that I've been doing for malaria surveillance. That's all from me. Thank you very much. I'll give it back to the moderators. Good morning. Or is it afternoon already? Yeah, good morning. Thank you.
Thank you, Dr. Henry. An excellent presentation. Very impressive body of work. Thank you so much. So we sincerely thank all of our speakers, both on-site and online. We would like to invite Professor Gregorio and Dr. Henry to proceed to the panel discussion. However, I'm afraid we're running a bit behind, so I probably can only take one question and the rest will be sent to the presenters. Do we have one question on site? Yes, please. Yes. You have the microphone on the left and the right side, sir.
Thank you for the opportunity. Let me introduce myself. My name is Rifki from Public Health, Magister Public Health, University of Mataram. I would like to ask question to Professor Apotheker Aulia. We know difficult it is to reach remote area with vaccination, right? In your opinion, what strategy should local government use to reach remote area with vaccination? And how can they guarantee the safety of vaccine given to the patient or children in remote area? And my second question is for Prof. Kian Jiem Lin. Earlier it was mentioned that was of the metabolic syndrome is diabetes, right? In pregnant, or we call diabetic gestational. And my question is, does the severity and duration of maternal hyperglycemic directly correlate with risk severity of stunting in children? Thank you.
Thank you. Professor Au.
Thank you very much for the question. So, yeah, how to make sure the safety, and then how to strengthen the efforts in terms of vaccination services in local government. Yeah, so currently the the Minister of Health just launched a system that can help how to monitor supply chain, how to monitor safety, everything through an online platform. So I think that's the thing that I want to share, that the government just initiated to launch a platform that can be helpful specifically for people in remote area, how to monitor everything related to immunization services, including to monitor the supply chain, including to monitor the safety. But again, from geographical challenges, I think one of the biggest challenge is we have very limited number of health workers in remote area. So as I presented in my slide, one of example from Pangkep, how one midwife she had to deal with many targeted people to be vaccinated, including how to manage the safety. And then in one of our studies also mentioned that ratio in terms of healthcare workers to number of doses to be delivered in remote area is becoming the biggest challenge. So human resources is very limited, and there should be a significant role from local and central government to deal with that issue as well. Yeah, I think that's all from my perspective.
If I understand your question, is there a relationship between maternal diabetes and early life stunting? Usually, when the mother has diabetes during pregnancy, it will result in large babies, large for gestational age. The babies are born with birth weight, 5 kilos of more than 5 kilos. Also, these babies with large for gestational age have a high risk for developing of metabolic syndrome in adult life. But there is also a possibility if the mother had chronic diabetes, for example, before she get pregnant, the diabetic women will have also a bad quality of the vascular system. It will result in a bad circulation of the placenta dysfunction. So it will also result in stunting intrauterine, in contrary to the mother who has not diabetic before pregnancy, but developing a pregnancy-related diabetes. It will result in large babies. So it is possible if the mother has diabetes, it will also result to stunting, but that is not very usual. Usually it will result in big babies.
I forgot to mention the application or the system that the Minister of Health just developed. The name is SMILE, stands for System Monitoring Inventaris Logistik Kesehatan secara elektronik. So now the Minister of Health just expanded the use of SMILE also to track vaccine logistics and to manage supply chains to ensure vaccines are delivered effectively and safely. And this system is encouraged to be used specifically for healthcare workers in remote area. Thank you.
Thank you, Professor Aulia, and thank you, Dr. Lim. the great amount of body of work exists in this room with both of you, and also virtually with Dr. Henry and also Professor Gregorio. Is truly impressive, and we truly thank for esteemed speaker of ours today for the honor to have you here. And we also hope for Professor Gregorio and for Dr. Henry for us to be able to welcome you in the next GHI 2027. So please join me in giving a round of applause for our 4 speakers. Thank you so much. And I will return the program to the Master of Ceremonies.
Thank you.
Thank you to all the speakers and the moderator for the insightful discussions on the integrated strategies for disease control in tropical and island regions.
To conclude this panel session, we would like to present a token of appreciation to our distinguished speakers in recognition of their valuable contributions to GHI 2025.
The plaque will be presented by our moderator, Dr. Mutia Chandradewi.
Please give a warm round of applause.
Thank you once again to all the speakers. To Dr. Mutia and all the distinguished speakers, please be seated.
Let us give them one final round of applause.
Ladies and gentlemen, we now proceed immediately to the plenary lecture 2 and panel discussion 2 session. The main theme for the session is strengthening health security in fragile and decentralized systems, featuring 4 materials and a panel discussion. This session will be moderated by Dr. Astri Ferdiana, Master of Public Health, PhD.
Dr. Astri Ferdiana is an assistant professor and the Master of Public Health Program Coordinator at the Faculty of Medicine and Health Sciences, University of Mataram.
She is also a senior researcher at the Center for Tropical Medicine at Universitas Gadjah Mada and a research consultant for a number of national and international organizations focusing on disability, infectious disease, and neglected tropical diseases.
Without any further ado, please welcome Dr. Astri Ferdiana.
Yeah. Thank you very much for the introduction. Good morning, ladies and gentlemen. I would like to welcome you to plenary lecture 2, which will highlight key issues in global health security, antimicrobial resistance, and equitable access to health service in resource-limited and constrained settings. My name is Astri Ferdiana, and I have the honor of moderating this session, and we will have an excellent lineup of speakers from different countries joining us both on-site and online. So our first speaker is Dr. Shukri Zawahir. He will be joining us on-site. He's a pharmacist and public health researcher from the University of Sydney, Australia. And right now he's a research fellow at the University of Sydney. And his research focuses on infectious disease control, antimicrobial resistance, appropriate use of medication, and also tuberculosis management. He has an extensive experience leading a number of epidemiological studies, including cohort study, cross-sectional studies, and also clinical trials, especially on TB. We would like to welcome Dr. Shukri on stage. Kindly start your presentation, and you will have 20 minutes, and we will give you notice if it's 5 minutes left and 2 minutes left. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi and good morning, everyone. Thank you so much for inviting me for this important conference. And today I'm going to share some of our experiences. We have been working in different countries in the region, especially on slow or silent pandemic, that is AMR or antimicrobial resistant. Today, I'm going to cover a few topics like, as you know, the context behind AMR. And then my talk focus on three different countries, discussing about challenges and what are the appropriate measures we should do, and we have done, and drivers of AMR, and what are the interventions to improve appropriate use of antimicrobial in these settings, especially low and mid-income country settings. As you all know, antimicrobial resistance is a silent pandemic. It's not noticeable like COVID-19 or any other pandemic, but it has consequences if we don't act now. According to WHO and many other studies, if we don't act on antimicrobial resistance now, by 2050, the consequences in terms of mortality expected like 10 million deaths, and also healthcare costs exceeding about $100 trillion by 2050. And immediate consequences of AMR, like long illnesses, increased mortality, morbidity, hospitalization, of course, increased costs, and also if you don't act now, we will be losing valuable antimicrobials or antibiotics for special need people like children and people seriously infected with bacterial infections, also vulnerable people. Why low and middle income countries? What is the problem with these settings? As you know, as compared to developed countries, the AMR is a huge issue, challenge in low and middle income countries. Especially if you look at the low and middle income countries, over-the-counter medication with antimicrobial is a big problem. Many studies reveal that around 60% of the people or public, they first go to community pharmacies in this region, low-income country settings, to get something for their mild illnesses, such as common cold, diarrhea, and cough. So, in these settings, the pharmacies, or community pharmacies, are like gatekeepers on AMR issues. And of course, we have poor surveillance system in low and middle-income countries, and also a laboratory system, and inadequate infection control and prevention. Of course, as a developing country, low income settings, socioeconomic and health inequities are also an issue in these settings. So inappropriate use of antimicrobials is a challenge in these settings. So I put from different studies, different publication and systematic review, I put together into the region to give a overall view of how antimicrobials are accessed from community pharmacy setting in these 21 low, middle, and developing countries. It ranges from 15% to almost 100% in the community setting. People have access to antimicrobial without any restriction. However, if you want to break down into the different studies we conducted in different part of this region, I'm starting with Sri Lankan study. We did some studies in Sri Lanka to understand this issue. So we have conducted overall countrywide standardized patient survey or pseudo patient surveys. We trained the public, selected people to act as patients or mystery shoppers and send them to the pharmacies to report their illnesses such as common cold symptoms and acute diarrhea. Almost 50% of the pharmacies immediately prescribe or dispense antimicrobials for these patients without any further queries. But remember, most of the developing countries or low and middle income countries selling antibiotics without a legal prescription is illegal or prohibited. However, it is happening in Sri Lankan context. And also, this is a bit interesting. So we also did a in addition to standardized patient surveys, we also did a study called quantitative survey or questionnaire-based surveys among the same pharmacies. And then we self-reported, the second one is the self-reported one. Self-reported survey indicates inappropriate or selling antimicrobial without prescription is 19% as compared to mystery shoppers, which it is 41%. It's a huge gap between self-reported and mystery shoppers or standardized patient survey, so due to Hawthorne effect. And similar things we have done in Vietnam. In Vietnam, we selected 4 provinces, 2 from south and 2 from north, and across 40 districts. And we did a standardized patient survey about 1,500 pharmacies across this region. And then we found the same issue here as well. Oh. All right, okay, so thanks. So the same issues like common cold, acute diarrhea, and also Vietnam is one of the TB high burden setting. So we included presumptive TB symptoms cases, also MDR TB symptom cases. And these trained mystery shoppers went to the pharmacies, reported the symptoms, and unfortunately about 90% of the pseudo patients visited these pharmacies got antibiotic without any issues. Any questions? Though even in Vietnam, prescribing antimicrobial is prohibited without a prescription. And diarrhea was about 50%, and then MDR and presumptive TB was about 70 to 90%. However, if you look at this picture, if you look at this one, it's an interesting one. When patients or pseudo patients presented these cases, in the pharmacies, the pre-prepared, very nice, different colors of tablets are already pre-prepared, and immediately they give to these patients without any further questions after reporting the symptoms. And it is very hard to identify even because it's already ripped off from the strips, right? And mostly, in both countries, Vietnam and Sri Lanka, they were given up to 1 to 2 days of doses of antimicrobials or antibiotics for patients with these symptoms. How about in Indonesia? So Dr. Asri and group like Pinta Research Group, they also done a very excellent job in Indonesia to look at how antimicrobials are dispensed in the pharmacy setting in a certain region of the country. And they also found the same mystery shoppers visit they did together. So they found like about 79% of them, like for viral common cold symptoms, were dispensed in the pharmacy setting, and also acute diarrhea about 47, and presumptive TB about 81%. It's a more or less similar to Vietnam and also Sri Lankan findings. However, we also conducted a survey among community or public to understand how self-medication and then demanding, because when it comes to the AMR and inappropriate use of antimicrobial, always is a big complex issue. Like if you ask pharmacy, they would say, patients are demanding, that's why we are dispensing. If we ask patients, it is easily accessible, this antimicrobial. There's a very complex issues. So we did a national survey among Sri Lankan public using validated questionnaire. We found about 90% of, or almost 100% of the people use antimicrobial within an year. Also, mostly they receive these antimicrobials or antibiotics from doctor's prescription, but only 11% they said they self-medicated without any doctor's prescription. However, most of this 11%, out of this 11%, 64% of the public, they use these antimicrobial for mild common cold symptoms. And also the source, they receive these antimicrobial for self-medication. Almost 100% of patients or the public, they receive from community pharmacies without any prescription. This is finding from self-reported survey in Sri Lanka. So, looking at all these pharmacies' perspective of these three countries and globally, it's a complex problem, as I said earlier. It's a, patient expectation is one part, the prescriber's challenge, regulation, poor regulations, and then pharmaceutical sector. So these are like interchangeable, complex issue. So we know inappropriate sale is a problem in these countries or in these settings. So we want to dive in deep and understand why it's happening. So we did further studies. It's a qualitative study we conducted in Vietnam. Our team, qualitative experts, we worked together as a team. They have conducted this study, and they found from this qualitative study why pharmacists are selling antimicrobial without prescription, also why public are using inappropriately or self-medicating with antibiotics. They found in the qualitative research, like self-medication is public, they use antimicrobial for self-medications, even like mild illnesses most commonly. And then the main drivers from the qualitative studies is like easy access, as compared to like, if patient wants to go to a hospital or doctor, it will take time, and maybe queue is there in the hospital, so there's easy access to the pharmacies. They just go and get the antimicrobials. And then also they need quick fix, right? So normally viral cough, as you know, like it takes 1 week or up to 10 days to resolve mild symptoms. But they want to get some kind of quick fix, so they want some kind of stronger medication. And as compared to go to doctor or hospital, getting antibiotics from pharmacy are cheaper. And sometimes the people, they don't get sick leave so that they can't go to a hospital to get the medication because of time consuming. And interestingly, also in the qualitative study, we found that people, they think like antimicrobial resistance is a side effect of antimicrobials or antibiotics. So these are the misconception and then inappropriate expectation of the patients towards inappropriate use of antimicrobials in Vietnamese context. And also, we have done another study to understand why pharmacies are, this type of things happening in the pharmacy context in Vietnam. So that we call it mapping study in Vietnam. In the mapping study, what we have done, again, the same area, same region, 40 districts in Vietnamese context, north and south, we have conducted a mapping study. We found like around 2,000 pharmacies. Interestingly, we found like density of pharmacy in the region where we did a study, about 102 pharmacies per 100,000 population. Can you guess how big is this density? Do you know what is the global density of the pharmacy for 100,000 patients and the population? Actually, global density is like a 25 pharmacies per 100,000 population. But when you look at the Vietnamese context, it is fourfold greater than the global context. And also, second point I'm highlighting here is 50% of the pharmacies, we could not verify their registration status in our study. Out of 2,000 pharmacies, half of them were, we claim they were not registered. So it's challenging. And a similar one we did, it's health. Then we want to understand what health system barriers in Vietnam to do like inappropriate sale, inappropriate use of antimicrobial. So we did the health system analysis as a part of our project. So in the health system analysis, we did the qualitative interviews with health policy people and the doctors and pharmacists. Also, we reviewed the health policy document, and we found these are the drivers of inappropriate drivers towards like health system drivers on inappropriate use of antimicrobial, starting with the poor coordination, lack of resources, also lack of pharmacists in the hospital system to implement and all those things. And also in Indonesia, the PINTA group has done as a part of their PINTA project, AMR project, they have done excellent work on understanding the barriers or drivers on inappropriate antimicrobial use by qualitative study. So they found like, owners pressure, finance motivation, and customers demand are the big barriers of antimicrobial resistance in Indonesia. And we also did some qualitative surveys in nationwide to understand the barriers, and through logistic regression, we developed a logistic regression model, and we found there are knowledge gaps. And then pharmacists believe and professional competency and availability of pharmacies are big drivers towards inappropriate sales of antimicrobial in Sri Lankan context. And also we wanted to understand barriers in order to, what are the drivers or factors impacting on inappropriate use of antimicrobial in Sri Lankan context. We did a regression model again, nationwide survey, and the regression model, we found that these are the drivers, like in terms of self-medication with antimicrobial, their knowledge about prescription requirements, situational use, and easy access to antimicrobial are the drivers towards self-medication with antimicrobial, inappropriate use of antimicrobials. Also, requesting antimicrobial from health professionals, the drivers were like previous experience, expect from pharmacies, and then last antibiotic use or experience of using antimicrobials, and expect from physician and for common infections. So from this Sri Lankan study, we have come up with a complex model towards self-medication experiences and situation. This is interesting model we came up. By this we can understand it's a very complex model, not only pharmacists or doctors or patients, there are so many things involved in addressing these issues. So to address this issue, now we can understand there are drivers are different from different countries. It's not always same Indonesia, Vietnam, and Sri Lanka, and same thing with other countries. So we have a WHO action plan, and it should be adapted into national level, During adaptation, there's implementation gaps you need to address as we discuss as a drivers, and the local implementation through local agencies or local groups should be involved. So we have implemented as a pilot version of the intervention program for pharmacies in Vietnam, and it involved many intervention programs, and we found significant reduction in antimicrobial sale, also patient counseling in Vietnamese context. Also, the similar things been done in Indonesian context, and they found also significant reduction in inappropriate sale of antimicrobial in Indonesia. These both studies are pilot versions of pilot version, and similar things we've been doing now in Sri Lankan context. So it is kind of now it's a kind of adapt the interventions, and then pharmacists we found like pharmacist-led stewardship is effective in the pilot version of our studies, and then strengthening community-level surveillance is also important. And also one of the important thing is regional collaboration, also understanding the local barriers in terms of implementing. So as a take-home message, I want to conclude with a few points. As you know, AMR is a global with local realities, and then low and mid-income countries shows the adaptability and resilience against AMR or with tackling with AMR, and empowering and frontline providers is the key, such as pharmacists. With that, I would like to thank all our collaborators and then investigators for these projects, and thank you so much for your kind attention.
Thank you very much, Dr. Shukri, and would you like to take a seat? And thank you for, I'm very honored that you cite some of my publications. Thank you. So we will have our next speaker, Dr. Andani Ekaputra from Universitas Andalas. Dr. Andani, are you online?
Yes, I am.
Good morning.
Morning.
Could you hear us clearly?
Yes.
Yeah, great. Yeah, my name is Asri Ferdiana, and I will moderate this session. So I would like to first introduce Dr. Andani. So Dr. Andani is a biomedical researcher and medical professional specializing in public health diagnostics, molecular biology, and infectious disease. He currently serves as Director of Business at Universitas Andalas in Indonesia, Head of Diagnostic and Research Center for Infectious Diseases, and Senior Consultant for the Indonesian Ministry of Health. His research focuses on developing diagnostic tools and vaccines for tuberculosis, HPV, and emerging infectious diseases. And during the COVID-19 pandemic, he was recognized nationally for his innovation, and he has also received multiple awards, including the Karya Anak Bangsa and Gatra Awards for his contribution to Indonesia's health sector. Dr. Andani, we are very pleased to have you here, and the screen is yours. You will have 20 minutes for your presentation.
Okay, I will present a moment. Baik, Assalamualaikum warahmatullahi wabarakatuh. Okay, thank you, moderator. Good morning, ladies and gentlemen. I will show my presentation about pandemic preparedness in decentralized health system. My name Andani Ekaputra from Faculty of Medicine, Andalas University, and also I head of Diagnostic and Research Center for Infectious Disease, Universitas Andalas, West Sumatra, Indonesia. During the COVID-19 pandemic, I was involved in handling the pandemic in Indonesia as an expert at the Ministry of Health. My current topics is related to the aspect of decentralization in handling the pandemic. I think this is very interesting but with a difficult, I think it's very, very difficult. Based on my experience, decentralization in the pandemic era is easy to say, but difficult to implement. It's very, very difficult to implement. Okay, ladies and gentlemen, we start. Our topic consists of three main subtopics: pandemic preparedness, and concept of decentralization in pandemic. So in the last presentation, I will give a conclusion. Next, global health crisis, particularly pandemic, pose significant challenge to public health, economy, and society worldwide. The pandemic will cause a global crisis in health, social, and even economic terms. We know is during the pandemic, economic growth in the whole country will decline, and transportation will be disrupted, and the movement of goods, people will be limited. Who is responsible for dealing with pandemic in the country? Is it at the central or regional government? We conduct centralization or decentralization. The big question is how big a role do region play in the preparing everything to face a pandemic? Ideally, my opinion, region should be given authority as a part of the decentralization mechanism. So I hope the next pandemic we can prepare region to preparedness to pandemic. This presentation aims to explore nature of pandemic global health crisis, their impact, and the importance of preparedness in related with central and decentralization aspect. Next slide. Okay, what's pandemic? What is pandemic? It's the best question. I think it's easy to answer there 2020. But before, I think more people don't know about pandemic. Pandemic is the occurrence of an infectious disease over a whole country or world at a particular time. The pandemic refers to worldwide spread a new infectious disease affecting a large number of people across a different country or continents. So many people will impact from pandemic. Not only one country, but more country. Next, if we see about pandemic have a cure of historical record. So it's started at 165 AD with Antonio Platt. So many long time. If we say about pandemic, virus are the most common cause of pandemic. Some virus-related incident includes Spanish flu 1918 with 20 and until 50 million deaths. It's M1 influenza with 2009 and COVID-19 pandemic in 2020 until 2023 with mortality more than 700 million and mortality 7 million. We can see it's the good facility of medical services, a growth mortality until 7 million. Okay, and next slide. I will discuss about what's pandemic impact. We conclude the impact pandemic to three aspects. The first aspect, health, second, social, and next, economic. Public, if we discuss about health perspective, we can see morbidity and mortality rates, as well as the burden on hospital, related the provision of medicine, beds, and medical personnel and other resources. My experience during the pandemic demonstrated the limited capability beds. You can see many waiting list a patient to the hospital. Oxygen, limited in oxygen, and we got many information. We have got many information about death related with insufficiency oxygen, the limitation on oxygen, which require a highly effective response. I don't want to repeat this situation again. So we must prepare better. From the social perspective, the pandemic will cause fear and reduce interaction. Several research reports indicated that a large proportion of hospitalized patients exhibit high level of stress. High level of stress. It's thought to contribute to death or serious illness. So we know the mortality in the patient not only cause of viral infection with many mechanisms, but also related with stress. Next slide. How about pandemic preparedness? Okay, pandemic preparedness in ongoing effort and remains a crucial public health priority anchored on two overall outcomes. The first, to minimize serious illness and overall deaths, and second, to minimize societal disruption among populations as a result of pandemic. So in this case, we have two aims related with pandemic preparedness: to minimize serious illness severity and deaths, and second, to minimize social disruption among population. Pandemic preparedness, if you see pandemic preparedness base is evidence-based information technology, communication system, and is part of universal health work. In this slide, related with pandemic preparedness. Pandemic preparedness and response refers to be comprehensive. So as comprehensive multi-layer strategy implemented by government, organization, and community to ready themselves for an effective manage infectious disease outbreak with a potential to spread globally. Based on our experience in COVID-19 pandemic, we see revealed critical gaps in preparedness. We see unpreparedness in facing the pandemic, poor coordination between central and regional government, weak facility support, and many more. Preparedness must cover sigma aspect. Okay, sigma aspect, namely communication, One Health approach, planning system, legislation, research, and risk assessment. This six aspect will then expand to 11 activities, include therapy, vaccine, diagnosis, biosecurity, infection prevention and control, genomic, laboratory capacity, surveillance, and include modeling, mathematical to machine learning, or artificial intelligence maybe. Okay. If you look deeper in the aspect of health service preparedness, include medical equipment, include medical institutional, medical workforce, surveillance system, data and system, information system, and structure governance. The government play a role in synchronizing work, building collaboration between central and regional government, private and government hospital, and communication channel, include information technology. In this slide, next slide. Okay. In this slide, I saw an example surveillance conducted by Ministry of Health to assess the impact of travel and population migration in the increase related with increase of the cases COVID-19. This activity is difficult if conduct in a single region, maybe in local region. So this activity, this report is very good to develop by government, national government, I mean. So we can know if the developed by local government is still very limited. But if developed oleh central government, we can good information, better information. So interaction by one country, one district and another district, we can know about it. Okay, next. Okay. Many questions raised regarding our relationship between the central and regional government regarding the handling of the pandemic. What's wrong based against pandemic? Each one has proven to be most effective strategy. How political system reacted to the emergency crisis. What practice will we learn from central and decentralized country? Do intergovernmental relations play an important role in fighting the COVID? There's many questions related with aspect decentralization in pandemic preparedness. So I think we can discuss by one, but I will try to simplify them in the few slide. Next slide. What is decentralization? What is decentralization? Decentralization can be described in general terms as the socio-political process, power sharing, I think. Power sharing arrangement between central government and local authority in planning, management, and decision making. But, okay, next slide. But I found negative aspect from decentralization. Yeah. Decentralization related with negative aspect decentralization. It's related with capacity constraint, finance functionaries and staff at local level for support or direction from the central. A lack of clarity about the role and responsibility of managing local service. In the new setup, and poor coordination between central government and local authority. But in other side, we can positive impact from decentralization, more rational and unified health service that cater for local needs and preference. A reduction of health inequality, community involvement, that improve intersectoral coordination. If we develop a decentralization aspect. Okay, next. The issue frequently discussed in the aspect of decentralization are authority, responsibility, finance, and resource. During the pandemic, the core aspect must be structured in such a way the implementation is easier. Region must receive clear information and guidelines regarding funding, work system, and coordination system. A system that is built in a coordinated manner between a central and regional government will have an impact in the form, the level of use health service facility, the quality of service through improving resources, and guaranteeing continuous policy improvement according to the conditional of its region. Okay, slide. In this slide, I will explain how a data system is needed to guarantee the relationship between the central and regional government. During the COVID-19 pandemic, my experience, the IT system built by central government was still equipped directly by region, but policy were issue central. The center, next slide. The center must provide full support to the decentralized system. Without this support, the activity in the region are wanted not be run well. Increasing level emergency and corrective local public health service delivery, prevention, intervention, mitigation, supporting social and etc. So in this case, the central must full support the region. And next, when conclusion by my presentation, I will give a conclusion. The pandemic is a major disaster with significant health, social, and economic impact that require comprehensive response. A local-based approach is needed, but it requires central government support to ensure equitable outcome across all regions. Thank you very much for
Yeah. Thank you very much, Dr. Andani, for your insightful presentation and sharing of experience. Would you like to remain on the screen because we will have a panel discussion at the end of the speech? Thank you. Yeah, so our next speaker is presenting her work online from the Netherlands, and it's early morning in the Netherlands, I guess. Good morning, Anne.
Good morning, Dr. Asti.
Morning. So, yeah. So, Dr. Anne Schoenmakers is from NLR until no leprosy remains. And she has been very kind to wake up very early to deliver her presentation. And I would like to introduce her. She's a medical doctor and global health professional from the Netherlands, who serves as an international project manager and medical advisor at NLR Until No Leprosy Remains is an international organization working on leprosy elimination, including in Indonesia. Anna leads Dr. Schoenmakers leads major international projects on leprosy prevention and integrated skin health. And her work focuses on improving early detection, strengthening local health system, and advancing community-based strategies towards leprosy elimination. Dr. Schoenmakers, yeah, can you hear me clearly?
Yeah, I can hear you clearly.
Okay, great. So we will share your slides, and if you need it to be forwarded to next slide, just let us know. So Dr. Schoenmakers will present her lecture on tackling neglected tropical diseases in under-resourced settings. Dr. Schoenmakers, the time is yours. You will have 20 minutes.
Yeah, thank you so much. And thank you all for having me. I'm delighted to speak at this conference. So let's go to the next slide. Yeah, as Dr. Asli already mentioned, I'm working for NLR, an NGO based in the Netherlands, and we work with an alliance organizations, including NLR Indonesia. Next slide. And I will first go into the topic of NTDs and also the WHO NTD roadmap. Afterwards, I will share some examples which can help to eliminate NTDs in this sort of setting. For example, the WHO Skin NTD, the information platforms Info NTD and InfoLab, and some innovations in leprosy control. Next slide. Yep, next slide again. Thank you very much. So NTDs are neglected tropical diseases, and there are 21. And they have several causes, for example, toxins, as you can see in snake bite and vomiting, but also bacterial infections, such as in leprosy or in jolts, fungal entities, such as mycetoma, but also protozoans and helminths, and of course viral entities, such as in rabies and dengue. Leprosy is one of the bacterial entities, but also Noma is thought to be caused by bacteria, and Noma is an entity affecting the face, which is a very lethal entity in children, and this was the last entity added by the World Health Organization to this list. And in total, 1.5 billion people from 149 countries are suffering or at risk for NTDs. Next slide. And there are some cost-cutting issues between NTDs. They are mainly prevalent in tropical areas, in impoverished communities, and they're often associated with disability, stigma, and exclusion. And they have not only health consequences related to physical health, but also social and economic consequences. And they are neglected because they are almost absent from the global health agenda and also receive limited funding compared to other diseases. And it's estimated that together the entities cause around 120,000 deaths and 14.1 million disability-adjusted life years lost annually. Next slide. The World Health Organization has set targets to combat NTDs, and they really focus on prevention, control, and elimination. And this is all outlined in their roadmap towards 2030. Next slide. One of the main focus points in that roadmap is that 90% reduction of people requiring interventions for NTDs in 2030. And they think important way to achieve this is to integrate approach to NTDs. So not to work in silos, but really to focus on targeting multiple entities at the same time. Next slide. And therefore, I would like to talk about the WHO skin app, because in the roadmap, like I said, WHO is speaking about an integrated approach, but also about capacity building to ensure high performance programs. And because there are often not sufficient numbers of medical specialists, for example, dermatologists, in settings where entities are prevalent, also primary healthcare systems need to be strengthened. Next slide. And this is further recently been announced as well in the WHA skin diseases resolution, where they say that skin diseases are a global health priority and they need urgent attention, and these include skin diseases which relate to neglected tropical diseases, also called skin entities. So this is the NLR Skin app, which was developed a few years ago, and this is a free application which you can download on your phone with Wi-Fi, and after that it works offline, and health workers with limited experience in detecting skin diseases and skin entities can, when they see a patient on the app, highlight where they see skin lesions, what kind of lesions they see, and then they'll see a screen with a differential diagnosis. As you can see, for example, leprosy and Kaposi sarcoma are included in the differential diagnosis. And if they then choose one of the diagnoses, they see photos, but also diagnostic and management advice. Next slide. And the skin app has been researched also in the Pet4Lab study. And based on those research results, 4 new diagnoses were added: Noma, the entity I mentioned before, and urticaria folliculitis. And the NLR Skin app has now been adopted by the World Health Organization. So NLR will stop hosting the Skin app next year because the World Health Organization has taken it over. And they are also going to include an AI function so that people can also take a picture of a skin disease and then differential diagnosis will come up. You're still looking for more photos, so if you work in dermatology, please reach out. And I would advise everyone to download the app. Now I'll mention 2 other platforms which can help to combat NTDs, Info NTD and InfoLab. Next slide. If you look for more materials or more information on NTDs, these platforms are there for you. Next slide. And this is what the platforms look like. So there are two different websites. One is focusing on NTDs and their cross-cutting issues, and the other one is focusing on leprosy only. Next slide. So the Info NTD platform in 2024 had more than 6,000 unique website users from 200 countries, and they all had access to more than 6,000 resources focused on NTD elimination. And over 5,000 of these resources are for free. If you're looking for a scientific article which is not for free, you can just easily go to Info NTD and email them, and they will buy the article for you, making sure that scientific information is available for everyone. And they also have training materials and toolkits available, and for example, assessment skills on the website. And one of the toolkits is the stigma guides, where you can learn more about stigma in NTDs and what you can do to avoid stigma. And the stigma guides are 4 interactive modules, which also include videos and assignments. As I said, InfoLab is really focused on leprosy, and they have more than 40,000 unique website users per year from 200 countries, and they have access to more than 31,000 resources. And this also includes guides, toolkits, best practice descriptions, and scientific articles. So what can Info NTD and InfoLab do for you? Besides the free full article delivery service, which I mentioned, they can also help with literature researches. They can share toolkits, training materials, and other materials. They also have a news page and with events list related to NTDs. And you can share your own content via InfoLab and Info NTD to make sure that the broader audience sees your great work. And you can also subscribe to their monthly overview, which is a great newsletter where all important articles and tools published are listed from that previous month. And because sharing is caring, Info NTD and InfoLab is asking everyone to contact them if you have any materials related to NTDs or to lepers. And you can do so by emailing info@infontd.org or info@infolab.org. And you can also stay up to date as stated, so scan this QR code to sign up for the Info NTD newsletter if you'd like to learn more about Info NTD and all the events related to NTDs. And you can do the same for InfoLab by scanning this code. So now I would like to go a bit deeper into leprosy, as I mainly work on leprosy, and I think this is a great way to use one disease as a case study also for other NTDs. Leprosy is one of the 21 NTDs as stated. It's a bacterial disease caused by Mycobacterium leprae, and it affects the skin, the mucosa, peripheral nerves in the face, hands, and feet. It's often a clinical diagnosis. There's no good blood test available yet, and transmission happens via untreated humans to other humans via droplet infections from the mouth and nose. Prolonged contact with an untreated patient is needed, and a lot of people have natural immunity for leprosy, but not all people. And leprosy is still around, so it's important to really work on this disease because it's one of the oldest diseases of mankind. Leprosy treatment is a combination of antibiotics for a duration of 6 or 12 months, depending on the leprosy type. And this medication is free of charge, and WHO gives the medication to the countries, and countries can then give it to the patient. And after starting medication, people are no longer infectious, and early treatments can also prevent disabilities and stigma. It's important to know that leprosy has a long incubation period. This can even be 20 years, but it's on average 4 to 5 years. And during this period, someone is already contagious, and there is no good test available to see which people from the incubation period progress to leprosy clinical disease and which people won't. Next slide. So globally, every 3 minutes, someone receives a leprosy diagnosis, and around 5 in every 100 new cases is a child. And that is a sign that still recent transmission was ongoing in the area where that child was diagnosed. So that leprosy is still being transmitted. 5% of the new patients already have visible disabilities, but this number is higher in certain settings. For example, on the African continent, this is around 10%. And it's estimated that between 2 and 3 million people are living with disabilities caused by leprosy. So globally, it is quite a big cause of disability. What we see is that last year there were 174,000 or 172,000 new patients diagnosed, but we think that many hidden cases are still not being detected. Next slide. Top 3 of the diagnoses were seen in Indonesia. That is the 3rd country globally with the highest number of new leprosy cases, with 8.5% of all cases globally. After that, Brazil, and as you can see, India is the biggest country. Over 50% of the global cases are diagnosed in India. As you can see, the global trend of leprosy is that prior to COVID, it was going down, but very, very slowly. We can also almost say that it was plateauing. During COVID, because of shift of health workers' priorities, of course, there was a dip in the detection of new patients. And after COVID, we saw an increase again of new patients being detected. Besides medication, since a few years, we now also have prevention for leprosy, which is 1 single dose of the antibiotic rifampicin. And research showed that this protects around 57% of people developing leprosy. This preventive medication is also called SDR-PEP, single dose rifampicin post-exposure prophylaxis. And this works during the incubation period. So it's given to contacts of an index patients who don't have leprosy symptoms yet. Hopefully there we can give them this 1 dosage of antibiotics, which clears the body from bacteria and therefore stops disease progression to clinical disease, but also stops transmission to others. Next slide. So why SDR-PEP? It is a control strategy which helps, which is important because early case finding and only treatment was not enough to stop leprosy, as you could see from the previous graph. And transmission already starts during the incubation period, so we really needed an intervention there. And unfortunately, there was no vaccine yet for leprosy, so therefore this is the only one of the only prevention methods available now. Next slide. And there was a modeling study done by a previous colleague of mine, Dr. Taal, together with Erasmus Medical University Center, which showed that a reduction of 50% is possible in 5 years' time with SDR-PEP when 110 countries are giving it out to contacts of leprosy patients, and a 90% reduction of cases is possible in 22 years. Next slide. SDR-PEP is cheap, well accepted, and side effects are rare. Antibiotic resistance is not expected, and it's already used in 37 countries, including Indonesia. Next slide. And it's also in all the WHO guidance documents. We also noticed that SDR-PEP is helping health worker motivation and the strengthening of the global leprosy control. Next slide. Which is important because the previous study from Ethiopia showed that the health workers there, for example, only 18% were able to diagnose leprosy correctly. So we really needed this boost in leprosy control. Next slide. So here are 2 countries which used SDR-PEP, and you can see that in Morocco, the number of new cases really went down. And also in a district in Nepal, we saw an 82% of reduction of child cases after introducing SDR-PEP. So who are eligible for SDR-PEP? Those are household contacts, neighbors, social contacts or community contacts who live in a high endemic area. And there are various approaches you can use, for example, the standard approach where you include the 20 closest households or contacts of a leprosy patient, or a blanket approach where you target the entire population of an area in a certain geographical setting. Or you can also use the skin camp approach, where you go with a mobile skin health clinic to a community where leprosy is prevalent to see if there are more cases and hand out preventive medication. Next slide. And in Indonesia, various approaches are used, including the close contact approach and the blanket approach, which is helpful for example, more remote islands. Next slide. And to decide which approach to use, you can use the SCRPEP decision tool. Next slide. And this tool really supports to select the best approach for your setting. And it can be used at local level, but also at national level. Next slide. It includes a description of the approaches, but also a flow chart to select which approach is best for your situation, and a checklist for requirements needed. Next slide. And it's important to have requirements like well-functioning health services, trained staff, but also resources like sufficient medication, of course, and you need to know what the stigma and endemicity levels are. Yeah, next slide. And this is what a flowchart looks like. And if you go to the next slide, you can see, for example, an area which is high endemic with a lot of stigma, and skin camp could be a useful approach. Next slide. And skin camps, like I said, bring dermatological care closer to communities, and you really target the whole community of an index patient, giving out SDR-PEP, but also medication for other skin diseases and screening for leprosy and other skin diseases. And it's not needed to share the disease status of the patient. Skin camp. Next slide. Next slide. So, yeah, we saw in skin camps that around 50% of the people joining have skin diseases, and 1.5% of the people have leprosy. So this is an important method to detect leprosy and skin diseases. Next slide. And this is an example of all the skin diseases and skin entities we saw. Next slide. Next slide again. So previously for leprosy elimination, it was stated that it's eliminated as a global health problem if there are less than 1 per 10,000 population prevalence. But we found that when this was reached, most countries stopped investing in leprosy control, which resulted in plateauing of the number of cases. And therefore, new definitions were defined on leprosy elimination. Next slide. And these can be found via WHO website. Next slide. And yeah, this tool is really used, the LEMIT, the Leprosy Elimination Monitoring Tool, which can be used from district level, regional and national level. Next slide. You can fill in the number of leprosy cases and the number of child cases in the previous 10 years in your area. Then click on automatic phase classification. Next slide. And you'll see where you are in the leprosy elimination process, and green is of course going towards the right way. Next slide. And from with this process, you can really see in which phase you are doing for elimination. Next slide. Next slide again. And you can also create maps, seeing where you really need to target your interventions. Next slide. And this is different than GPS maps, but if you use both GPS maps and the LEMIT maps, you can really target your intervention to reach as many people as possible which need your intervention. Next slide. And this can really help also to largely scale up PEP and eliminate leprosy in your region. Next slide. And Jordan was the first who reached elimination of leprosy, and of course we hope that Indonesia, or at least subnational levels of Indonesia are next. Next slide. Next slide. So if you're interested to learn more about leprosy, reach out to NLAR Indonesia. You can also collaborate with them on funding opportunities, on grants, and write proposals together with them for research funding, for example, from the Leprosy Research Initiative. Next slide. Yeah, this is the history. NLAR Indonesia is around since 1978, so they have a lot of experience, doctors and researchers working for them. Next slide. So reach out to NLAR Indonesia to learn more and for collaborations. And next slide. And reach out to the Leprosy Research Initiative, because there you can get research funding yourself on leprosy, but also on other skin entities.
I'm
Next
sorry,
slide.
Doctor, you have 1 minute.
Thank you very much.
Right on
Yes,
time.
terima
Okay.
kasih.
Thank you very much. Terima kasih. Applause for Dr. Schoenmakers. Yeah. Thank you very much for your inspiring presentation and your continuous work in addressing neglected tropical disease, especially leprosy. And if you would like to remain on the screen while we proceed to the next speaker, because we will have a panel discussion at the end of the session. Thank you very much. So I would like to check with the committee if Dr. Paul Gobardan is online or he's still offline. Okay, so our next speaker is also coming from the Netherlands, Dr. Paul Gobardan, PhD from Amphia Hospital, the Netherlands, who will present expanding access to surgical and oncological services in resource-constrained environment. I would introduce him, although he's not with us this afternoon, but he has been very kind to prepare pre-recorded material. So Dr. Paul Gobardan is a consultant surgeon and board member at Amphia Hospital in Breda, the Netherlands. He specialized in breast, colorectal, and liver surgery with a strong focus on minimally invasive and robotic surgical technique. And with over 2 decades of surgical and academic experience, he has contributed extensively to clinical research in gastrointestinal and oncologic surgery. So is the video ready? Yeah, sorry? Oh, okay, it's in the process. I think the audio is not yet audible.
Morning, everyone. Thank you for the invitation to speak at this interesting conference. My name is Paul Gobardan, and I'm an oncological surgeon from the Netherlands, where I work at the Amphia Hospital. In addition to my work as a surgeon, I'm also one of the board members of the medical staff at my hospital. I would like to tell you a little more about how we organize oncological care in the Netherlands. The Netherlands is a small country located in northwestern of Europe. But despite being a small country with 18 million inhabitants, we have an extremely high population density. If you consider the surface area of the entire country, including water, there are 433 people per square kilometer. In the Netherlands, specialist medical care is provided by 3 different types of hospitals. The academic hospitals, 7 in total, which are located in the larger cities in the Netherlands. And these hospitals are affiliated with the various medical faculties and universities in our country. They therefore educate students and provide specialist medical training. But they also perform a great deal of research and are responsible for tertiary care, such as transplants. Furthermore, there are 27 STZ hospitals, STZ stands for Foundation of Top Clinical Hospitals, which means that these hospitals are also responsible for training and research. Furthermore, we have 35 general hospitals throughout the country that provide basic care. To put the size of the Netherlands into perspective, I've superimposed the map of Indonesia on the map of Europe. This will certainly made me think, you live in such a large country with so many inhabitants. How do you manage all of that? That's why it's interesting to explain how we organize things in the Netherlands, and of course I'm very interested how care is organized in Indonesia. Perhaps we can learn from each other. As I mentioned, the Amphia Hospital is one of the 27 STZ hospitals in the Netherlands. Amphia is located in the city of Breda. It's in the south of the country. And we deliver care for approximately 400,000 inhabitants, and for special care like cardiothoracic surgery, this is even more. The Netherlands is divided into 7 regional oncology networks, as you see on the left. These networks strive to further improve the organization and quality of oncology network care. Amphia is part of the Southwest region, with the Erasmus Medical Center as its academic partner. Actually, there are 2 oncology networks in the Southwest region, Concord and Embrace. Amphia is part of the latter, Embrace, and I will return to that shortly. The oncology networks work with several important themes. First of all, shared care. The shared care model is a tool that regional oncology networks use to efficiently and effectively organize oncology care, ensuring that every patient receives appropriate oncology expert care. The model is based on the echeloning of hospitals into 3 tiers, with the regional multidisciplinary team, MDT, as the pivotal point. The echeloning is tumor specific, and the regional oncology network and all collaborating institutions, locations, teams, and professionals function as a single organization, as if they were working under one roof. This generic shared care model is applicable to all aspects of oncology care. The second theme of oncology networks is transparency. Transparency is key when it comes to quality of oncology network care. Regional oncology networks strive to clearly demonstrate what they do and how well they perform. Transparency and data sharing are crucial for several reasons when it comes to quality and systematic quality improvement of oncology network care. Patients want to know how and in which hospitals the regional network has organized care for their specific condition and how good the quality of this care is. This helps them in the choices they make regarding their treatment. Healthcare professionals need data to evaluate and to improve care, and health insurance wants to know where they can purchase good oncology care. Oncology care is increasingly becoming network care. How do we, as regional oncology networks, make the quality of network care transparent? How do we measure and assess quality within the network? The oncology networks are working on a national network standards in the form of a set of concrete and verifiable quality criteria. To gain insight into data, there are 2 important organizations in the Netherlands that help us as healthcare professionals, policymakers, but also patients to improve healthcare. First, the Netherlands Comprehensive Cancer Organization, abbreviated in Dutch as IKNL, and DICA, the Dutch Institute for Clinical Auditing. You can look them up on the websites I put for you in the bottom of the screen. The Netherlands Comprehensive Cancer Organization IKNL, is an independent knowledge institute for oncological and palliative care. Their mission is to reduce the impact of cancer. They aim to do this based on insights from real-world data in the Netherlands Cancer Registry, abbreviated NKR. IKNL makes a significant contribution to reducing the impact of cancer by collecting and disseminating essential and reliable data and providing information and insights to healthcare professionals, policymakers, and researchers. IKNL collects data on the diagnosis, treatment, and outcome of all newly diagnosed cancer patients in the Netherlands Cancer Registry, the NKR. The NKR data can be used to transparently discuss the quality of care at the regional level. And important to know for privacy, IKNL does not provide identifiable data to third parties without the express permission of the hospitals concerned. And in addition to the Netherlands Comprehensive Cancer Organization, DICA, the Dutch Institute for Clinical Auditing, has been active since 2010. The Dutch Institute for Clinical Auditing, or DICA, is an independent knowledge organization that organizes and supports the development and implementation of 26 quality registries. DICA was founded in 2010 at the initiative of healthcare professionals. Auditing offers medical specialists and other medical professionals insight into the quality of care they provide and the opportunities for improving patient treatment. This way, we improve healthcare together. All Dutch hospitals and many independent treatment centers participate in the DICA registries. DICA is constantly developing so that we can increasingly apply the available healthcare data. They do this by optimizing their registrations, further developing their dashboards, and facilitating peer review sessions through a variety of projects. I just mentioned, there are now 26 quality registers within DICA. For example, the DRCA, the Dutch colorectal audit, and the DHBA, the Dutch hepatobiliary audit. But there are also other audits. For example, the DHFA, the Dutch hip fracture audit, or the DSAA, Dutch surgical aneurysma audit. Most of these audits start within surgical practice. Surgeons want to know, what are my outcomes? I mentioned earlier that Amphia is part of the Embrace Oncology Network. Embrace consists of several different types of hospital. The Erasmus Medical Center is our academic partner. But there are also 3 other hospitals similar to Amphia, also 3 STZ hospitals, and 3 general hospitals. Our Embrace network also includes 2 radiotherapy centers that, together with the hospitals, are committed to improve the care for our oncology patients. The Embrace Cancer Network currently has 10 active tumor network groups: colorectal, breast, melanoma, pancreatic, thyroid, upper GI, bladder, and testicular, prostate, kidney, and palliative care. All the 10 tumor network groups include healthcare professionals from participating hospitals and radiotherapy centers. In addition to frequent consultations, the tumor network groups also hold an annual outcome meeting. Various topics are discussed during these annual outcome meetings. For example, at the annual outcome meeting of the colorectal tumor network group, we discussed things regarding number of diagnoses, number of resections and the various stages, information on neoadjuvant therapy, the various surgical referral patterns. Are there special T4 referral patterns? Because in the Netherlands, we see a few T4 colonic cancers due to the National Population Survey implemented in 2014. Information regarding the various surgical treatments and the outcomes of surgical treatment, and last, information on systemic therapy. I will give a few examples of how the differences between hospitals are discussed during such a meeting. On this slide, for example, we see the embrace region on the left and a diagram on the right showing the incidence of colorectal cancer over the different years. The figures are somewhat older, 2012 throughout 2016, but they serve as an example. What you can already see is that since the introduction of the population screening for colorectal cancer in 2014, the rising incidence has been decreasing. This is another example. On the left of the slide is an anonymized image showing the 7 participating hospitals in the embrace region. This clearly shows the differences in size of the treating hospitals. Note that this only concerns rectal resections for a malignancy. The image on the right shows the difference between the participating hospitals regarding the type of pre-treatment used for different stages of rectal cancer. These differences can be explained, for example, by the fact that the Erasmus Medical Center is the only academic hospital in our network and they treat primarily recurrent rectal cancer. Another explanation for the differences between the hospitals may lie in the interpretation of MRI scans, which we routinely perform in the workup of rectal cancer patients. The differences between pre-treatment with only radiotherapy versus chemoradiation therapy is a good example of this. The indication for the type of pre-treatment is made based on the characteristics observed on an MRI scan. Finally, the next slide is an example. On the left are the 7 participating embrace hospitals that examined the various treatment options for rectal cancer: surgical resection, endoscopic resection, or a combination of both. In most hospitals, the ratio between surgical and endoscopic treatment is the same. In the lower volume hospitals, surgical resection is more often resorted to. On the right is a diagram showing the percentages of anastomotic leakage, with the comparison between the embrace region and the Netherlands as a whole on the far right. As can be clearly seen, there are indeed differences in anastomotic leakage rates between the participating hospitals, with percentages ranging from 0% to over 20%. You could say these are enormous differences. It's important to note that these are outcomes that are reviewed annually, and in some cases the numbers are relatively low. I would also like to mention again that the Netherlands Comprehensive Cancer Organization has provided anonymous institutional level data to relevant institutions in the region. Each hospital was informed of the letter representing each hospital in each figure. And with these annual outcome meetings, the various hospitals can compare the quality of their services with similar hospitals in the region. These meetings are not used to point fingers at each other, but to learn from each other. For example, a hospital with the high anastomotic leakage rate, which has a huge impact on both patients and hospital costs, will then discuss the matter with a hospital with a low rate. Sometimes, with accessible How I Do It sessions, significant improvements can be achieved. In summary, I would like to offer the following. Data insight is key. With uniform data registration, it's possible to visualize differences between hospitals. Transparency. This transparency isn't intended to identify good or bad hospitals, it's meant to help us learn from each other. Only by being open to this can we move forward together. Safe environment. To openly discuss hospital outcomes, it's important that this happens in a safe environment. Give each other the space to be honest. Discuss case studies with each other. And most importantly, be open to further learning. And perhaps an open door, conducting research together connects. Don't just look at outcomes, but also work together to gain insight into what has been done. Sharing new insights and peering into each other's work is rewarding. Thank you all for your attention, and if there are any questions, I would like to try to give you an answer. Thank you.
Applause for Dr. Paul Goberdan. And we are pleased to have Dr. Paul Goberdan online. Dr. Goberdan, can you hear us?
Yes, I can hear you.
Thank you very much for joining us. I know it's such an early morning in the Netherlands. So thank you very much for joining us virtually. So we will proceed to our panel discussion. And because of the time, we will have only around 5 minutes, maybe 2 or 3 short questions. So I would like to invite the audience for any question for one of our speakers. Yeah, one in the back. Okay, would you like to come forward to the microphone? And please say your name and also which speaker would you like to address the question to? Okay, yeah.
Yeah, thank you. So, good afternoon. I'm Lila Faiza. My name is Lila Faiza. You can call me Lila. I am a Magister of Public Health student from Mataram University, Indonesia. So, yeah, thank you so much for your insightful presentation and on antimicrobial resistance and the challenges in low and middle income countries. I really appreciate how highlighted in the issue of an inappropriate antibiotic sales in community pharmacies, which is also relevant to our context in Indonesia. So yeah, I have question. My questions is for Dr. Zawahir. Considering similar challenge in Indonesia, what lessons from Vietnamese experience could be adapted to strengthen antibiotic governance in our health system? That's it. Thank you.
Thank you. Would you like to give a short answer?
Thank you so much for the question. Yes, it's an important question, and also it's a part of my presentation. I highlighted that regional experiences is important to tackle AMR. Yes, your question is like how we can incorporate or learn from Vietnam experience to uplift or protect antimicrobials in Indonesian context. Actually, yes, we have done many different types of studies, and which some of them I didn't even discuss today. One of the main learnings we got from Vietnam context is antimicrobial stewardship program in grassroots levels, such as like commune level hospitals and district level hospitals. So using a clinical pharmacists. So if we can, if you can think of like how we can use clinical pharmacists in order to improve antimicrobial stewardship program in the hospital setting, that are one of the learnings. We had from Vietnam these things, so we not need to do like 2-3 years pilot or studies to understand the things, because as I said, it's a problem is common across the region, but factors may be different in terms of implication. So one of those, then there are so many other factors we can discuss if you want later on. Thank you.
Thank you very much, Dr. Zawahir. And I believe if there are more questions from the audience, they can approach you directly. Any other question? Yeah, from also from the back.
Yes. Uh, uh, yeah. For the first time, I want to say thank you to all the speakers. But now I want to ask a question to Dr. Andani. Yeah.
He apologized for having to leave early. So Dr. Andani is not here, but you can still give your question, and we will we will send it to him
Yes,
virtually.
okay.
Yeah.
Thank you. My name is Dr. Malika. I'm from the Magister of Public Health Studies, University of Mataram, the second semester. My question is, how can pandemic preparedness strategies be adapted to local island contexts, such as Lombok, especially regarding intersectoral and coordination, health research distribution, and strengthening primary health care in remote areas? Yes, thank you.
Okay, thank you very much. The committee, did you record the question? Okay, great. Thank you, Dr. Malika. Any question? Yeah. Please come forward to the microphone.
Good afternoon. Please, I want to introduce myself. My name is Niwayandip Taningsi. I student in Magister Public Health in University of Mataram. I also work in primary health care. So I want to ask Mr. Sukri, in context of low and middle income like Indonesia, how do you see the role of primary healthcare system in serving as the frontline for antimicrobial resistant prevention, especially when diagnostic capacity is limited? Thank you.
Yes, it is very important question, and also it says like the one sort of action may not be applicable or in all the settings. So if when it comes to the primary healthcare setting, as I said, my previous response to the previous question, like for example, action plan or antimicrobial guidelines. There are in Indonesia and many developing countries, they have a lot of guidelines in order to use appropriately antimicrobial, but the national level guidelines are not applicable in grassroots level or lower level settings because of the resource restriction and all those things. So to improve that one, based on the national guidelines, we have developed kind of the guidelines, especially for the hospital, which are suitable for local settings in a resource limited setting. So one of those approaches we did in Vietnam, it was really impactful. In terms of community level, so resource limited settings, so if you want to go for mass media campaign or anything like something like that, in order to improve appropriate use of antimicrobial in community level, it is so costly and so millions of dollars may cost. But our approach was like community engaged program. So we did this program through community pharmacists, to their community. We trained the trainers, community members, community leaders, and women organization leaders and religious leaders. So they took the role and they passed the message to the community. It is also impactful and cost effective. So these are the few strategies, and there are a few more. We tend to do in the grassroots level or lower settings or rural settings in our studies. Also, we are doing the similar things currently in Sri Lanka and very rural level to improve appropriate use of antimicrobials in the community settings as well as hospital settings. Thank you.
Yeah, thank you very much, Dr. Zawahir. Unfortunately, our time for plenary discussion is up. And I would like to just give a brief summary. So thank you very much, Dr. Zawahir, Dr. Schoenmakers, and Dr. Gubadan for joining us on site and also virtually. And we have heard how challenges from your respective fields can be overcome and integrated to build resilient and equitable health systems. And we can see that the use of technology and also behavior change, field approach, involvement of the community can be strengthened to overcome these public health challenges. For those of you who still have some remaining questions, you can approach the speaker. Dr. Zawahir is here until this afternoon. And thank you very much for Dr. Schoenmakers and Dr. Gubadan. And we conclude this session by applause for all the speakers. Thank you.
Thank you to all the speakers and the moderator for an insightful discussion on strengthening health security in fragile and decentralized systems.
All right, to conclude this panel session, we would like to present a token of appreciation to our distinguished speakers in recognition of their valuable contributions to GHI 2025.
The plaque will be presented by our moderator, Dr. Astri Ferdiana.
Okay, please give a warm round of applause. To Dr. Astri and all the distinguished speakers, please be seated.
Let us give them one final round of applause. Distinguished participants, ladies and gentlemen, now we will have a lunch break which will be served on the first floor at the Cendrawasih restaurant, held in parallel with the poster walk session day 2.
Please enjoy your lunch, and we encourage you to visit the poster gallery and explore innovative research presented by our contributors in front of the main hall.
And a gentle reminder, the oral presentation session will be conducted online at 1:30 p.m. after the lunch break. So please ensure that you are aware of your assigned breakout room and presentation schedule.
We also kindly remind to all the participants to return to the main hall promptly at 3:30 p.m. or 15.30 WITA as we resume with the spotlight session. Thank you and enjoy your lunch.
Recording stopped. Okay.
Recording in progress. Recording in progress.
kirim ke saya. Saya kirim saya.
Hadirin yang kami hormati, kepada seluruh peserta yang masih berada di luar ruangan, kami himbau untuk segera masuk ke dalam Garuda Ballroom karena acara akan segera dimulai. Saya himbau sekali lagi kepada seluruh peserta yang masih berada di dalam ruangan, kami himbau untuk segera masuk ke dalam Garuda Ballroom karena acara akan segera dimulai. Terima kasih.
distinguished participants, ladies and gentlemen, welcome back. And now we are going to proceed to the spotlight session, Emerging Voices and Innovations in Island and Tropical Health, featuring 3 dedicated speakers and a discussion. This session will be moderated by Dr. Dewi Suryani, of Infectious Disease.
Please allow us to introduce our moderator. Dr. Dewi Suryani, Master of Infectious Disease, is a lecturer at the Faculty of Medicine and Health Sciences, University of Mataram, and a general practitioner at Mataram University Hospital. She holds a master's degree in infectious disease from University of Western Australia.
Her research focuses on dengue, infectious disease prevention, and community-based health intervention. Without any further ado, please welcome Dr. Dewi Suryani. To Dr. Dewi, the stage is yours.
Thank you very much for the kind introduction. Good afternoon, distinguished guests, colleagues, and our fellow participants. Welcome to our spotlight session, Emerging Voices and Innovation in Island and Tropical Health. My name is Devi Suryani, and today I have the pleasure as becoming your moderator for this session. This session brings together a diverse perspective and innovation that are shaping the future of health systems in islands such as Lombok and tropical regions. From primary healthcare transformation and climatic impacts and also vaccine research. This session highlights the breadth of innovative research emerging from our island, reflecting its growing contribution to global health and science. We are honored to have 3 inspiring speakers with us today who will share their valuable insights and experiences. Each speaker will have 10 minutes of their presentation, which will be followed by a panel discussion at the end of this session. I kindly remind all speakers to stay within the time limit to ensure that we have a rich and balanced discussion. So, without further ado, it is my pleasure to introduce our first speaker, Ms. Yuni Dwi Setiawati. She is the CEO and Chair of the Executive Board at the Summit Institute for Development. She holds a Master's in Health and International Development from Flinders University and a Bachelor in Nutrition and Dietetics from Gajah Mada University. She leads major public health and digital health projects funded by global organizations such as the Bill Gates Foundation and WHO, focusing on maternal and child health, digital innovation, and COVID-19 response. Ms. Yuni is an accomplished researcher and speaker with key publications in early childhood development and digital health standard, combining with her expertise in health system, nutrition, and digital technologies. This truly has improved the health outcome here in Lombok and Indonesia. So today, Ms. Yuni will present her research on driving primary healthcare transformation in Indonesia and globally through research, technology, and data-driven innovation. This presentation will explore how research and technology can accelerate the transformation of primary healthcare system, not only in Indonesia, but also globally. So please join me in welcoming our first speaker, Ms. Yuni Dwi Setiawati.
Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Nice to for having you here in the stage. And yeah, we are honored to be part of this great conference and global health.
And I would like to share about our most of the experience in the field related to the driving transformation, driving primary healthcare transformation in Indonesia and globally through research, technology, and data-driven decision making. So I'm here with my team from the SID, Summit Institute for Development. Over 25 years, we've been dedicated our time to improve the research and data to use for action in the community. And I would like to share more about it in the next slide, please. So we start 25 years ago doing a randomized control trial to involve 42,000 pregnant women in Lombok Island to assess the impact of multiple micronutrient supplementation to improve the infant survival. And the research suggests that 18% of infant mortality can be reduced through this multiple micronutrient supplementation that has shaped the global and national recommendations. So just recently, Ministry of Health then adopting the multiple micronutrient supplementation as a program. So we also co-founded the Open Smart Register platform. This is used by the frontline workers and now being used in 17 other countries worldwide. And we also founded the team-based care model. So this is the model that implemented to enable people working together as team to create impact for the community, and it's awarded as top 10 innovation by WHO. Then core partner, now we're working with the Minister of Health to accelerate digitalization in primary health care and covering several districts across the country using the standard of data interoperability, fast healthcare interoperability resource, or HL7 FHIR. And our vision and mission over 25 years never changed: to improve public health, to increase human resource, and use technology at the community level, and assess the impact, of course. Next. We progressing. We cover 10 districts across the country, and this progress actually because we have a strengthening collaboration with multiple national, international collaborators, including UNRAM. We very much working together to improve the utilization of technology, how to improve the human resource, and how we can use the data not only for reporting, but how we can use it for action. Next. This is the ecosystem that we use. It's not only single tool, but it's multiple tools working together. So long that it's using the same standard, don't worry, your data can be connected or interoperable, we call it. So we utilize multiple tools that distributing all of the service delivery in the community, so the data can be connected and can be seen by multiple actors. For example, the head of Puskesmas or primary health center, they can see through dashboard. Even the pregnant women can receive messages, reminder, and so on. I can explain later. Next. So you can play the video. This is one of the tools used by frontline worker. We believe with improvement of the work by frontline worker in the field, so the work of service delivery can be improved. For example, here the data collected from the field, including the task assignment, the location, what to visit, when to visit, it can be informed the schedule sent every day to frontline workers so they go to the field without, like having blind direction. I can have next slide, please. So here, maybe you can stop first. Stop the video. On the right-hand side, you can see people are going to the field, right? The midwives or the frontline workers like community health volunteers. They go to home visit. They go to posyandu or community health posts. So here we use dynamic worker support. You can play the video. Just like you have job, task every day, and you optimize the route. You go to the field, you focus on your task, and this task can be optimized. For example, your route is not, good enough. You have several tasks in a day, 5, 8 or so. Then you can see there, someone called Memi Hazlin, one of the frontline workers. They go to the field, and you can see from the big dashboard in your office or something. But here there are green light, there are green tasks, meaning that, this is completed. complete it, and you need to send the photo and the photograph and the signature of people who getting visited. Then you go check out to go to another visit, and there is a red there, meaning like this visit is not successful. So you need to find the photographs, and you can send also the reason why this visit is not completed. Then, okay, that's the demo. Another tools or another feature of the dynamic worker support is you can also see this is the timeline in the end of the day. They come back to the base camp or office. You can see the timeline of every health worker or every community workers. You can see the activity. You can see how long it takes for that person to come to visit and how long, the activity. Then you can create a report. So report contributing to the performance-based metrics for every individual. So in the end of the day, you can give feedback for every frontline worker in the field. What is the matrix? It completed including the success rate, the working duration, the check-in, check-out. Just like you in the office, you can have check-in, check-out, but this is in the community. Then you have also completeness of the visit, whether it be, you completing all the signature, you completing all the picture, and so on. So we create a matrix for individual performance. Next. Apart from giving tools to the frontline workers, the most important thing is also reaching out to the community members, in this case, pregnant women. So our case, we create the automated WhatsApp and also call center. So we call it helpline and helpline for mothers and families. So the idea is you get all of the numbers from the community, you send the message automatically. So it's not manual. Then it is personalized. It's not like, general information based on your condition. And this also created chatbot, like chatbot for education and specific needs you want. Then this is type of message that have been developed and used in the real world settings. Introduction, care gap messages. If you're pregnant woman, you're missing one of your care, you will get a message. Hello, Ibu A, you are missing your ultrasound. Please go to the puskesmas in the next day or so on. Next. So another type of health education that we created also chatbot. For example, here, just one example. In the HPV, human papillomavirus, we create health education. You can start, then you can find out about HPV, then you can find about the symptoms and assessment and so on. Then if you want to consult with the midwife or frontline workers or doctor, you can click, I want to consult, then done. So the online service, somehow people don't have WhatsApp, so we create call center. In the call center, it's not like you call person one by one, no. Is it created for massive approach? You can have 100 calls for a day, but whoever pick up first, so that you service them. So we call it the predictive dial. And this is really suitable for rural setting like in NTB. Next. This is the impact of when we did a cohort of pregnant women, 7,000 more, sending the message and not sending a message, give improvement in their care completeness, especially the laboratorium services. Here you can see this is required test for every pregnant woman. It increased significantly, especially for glucose, hemoglobin, and also hepatitis B. Next. And this type of messages, it served a month, 1,000 topics has been helped by this kind of connected tools, WhatsApp API, and also call center. Next. How do the mothers say? So they say okay, thank you for having this approach because I now not shy to talk about my pregnancy. If I have problem and difficulties, they say this is very useful. And they say they are very helpful to get a personalized message when the time they need and so on.
I'm sorry, Miss Julie, you have 1 minute more.
Okay, this is the last time. The last slide, maybe this slide? Okay, another one, because now AI is emerging, right? So we created a tools to help monitoring on compliance or adherence for pregnant women, like integrating the antenatal care flow with the multiple micronutrient supplementation compliance. So when it comes to strip or barcoding, maybe you can stop the video first. then it can connect, right? If the field worker come to visit the mothers, hello, how many strips or how many pills that you already consume? So it connect with the barcoding, and the barcoding, the information will come to the digital tools, the digital database. Then in addition to that, on the right-hand side, you can go. Now the pill is not in blister or, no, not yet. Okay, the Star MMS one. So it's not come only with strip or blisters, so it comes with bottle. How you want to calculate the number of pills consumed by pregnant women? So we integrate the AI to understand the pill consumed by one pregnant woman, having the prediction and also accuracy improved. And in the end of the day, you want to know how many pills estimated been consumed. Here, the picture comes from the field, and you know how many estimated there still remaining. Next. And if you talk about primary health care, of course, you need to get the data visible for, let's say, the head of Puskesmas, right? So we create a local area monitoring dashboard. This has been used nationally and will be rolled out to all of the Puskesmas around the country. It consisting of the heat map of the morbidity, and in the morbidity, it's not only just stagnant. So you can click and see how many people in the community, where they are, that needs follow-up. Next. This is the example of vaccination. In the right-hand side, you can see there are red and green. So that's the coverage of vaccination. It's not only just data, but if you click it, you know, like, oh, which one is the children or babies not yet vaccinated. So this dashboard is a drill down and also actionable dashboard to improve missing care gaps and also compliance. Next. Done. I think this one is about laboratory service. So we work very close with the FK Unram, with the medical faculty, to create like improvement in a laboratory service, especially for pregnant women, and we work with genomics and other workflow. Thank you. I think that's all. Yeah.
Thank you very much, Ms. Yuni, for the insightful presentation that highlights how innovation data can strengthen the foundation of primary healthcare, which Ms. Yuni has just mentioned. So we kindly ask Ms. Yuni, you can return to the floor, and then after the panel session, we'll invite you again. Thank you so much, Ms. Yuni. We will later on invite you back to the stage in the Q&A session. Big round of applause again to Ms. Yuni and her insightful presentation. Okay, continuing to our next speaker is from the Provincial Gender Equality, Disability and Social Inclusion, or GHI Coordinator for Skala NTB, which is Sinergi dan Kolaborasi untuk Akselerasi Layanan Dasar. The Provincial GHI Coordination for Skala NTB is an experienced professional with over 20 years in social inclusion and community development. For the last 2 years, he has been working closely with the NTB provincial government to promote inclusive, good governance and strengthening the civil society organization as development partners. He will talk about the impact of sea level rise on basic services. This talk will address how rising sea level affects access to essential services such as health, education, and social service, particularly in vulnerable island communities such as Lombok, and explore strategies to enhance resilience. Please give a warm applause and welcome the Provincial GHI Coordinator for Skala NTB. The floor is yours.
Good afternoon, everyone. Assalamualaikum warahmatullahi wabarakatuh. Allow me to take this time to present to you the result of our study for the sea level rising impact to basic services in Nusa Tenggara Barat, such as health, education, social, upon vulnerable people. This study is actually one of the Scala effort. this study is actually one of the scholars' effort in supporting evidence-based and inclusive policy making in NTB. So, allow me to introduce Scala to you in slide 2. Next slide. Scala is a sinergi, kolaborasi, akselerasi layanan dasar. This actually aim to improve by improving basic services such as health, education, and social in less developed region. So we help our output. One of our output is actually we help central ministry and local government in developing evidence-based policies and also inclusive policies in order to strengthen enabling environment for sub-national level. Our outcome is also improving the evidence-based and also financial system, and at the same time, at the same time, we also try to increase the participation of vulnerable groups in decision making. So go to slide 3. Now the Scala program areas are determined by the government of Indonesia and also Australia, and we are supported by 3 ministries, which is the Ministry of National Development Planning, Ministry of Home Affairs, and the Finance Ministry. Those 3 ministries provide technical support and also policies to help local government in creating much better and inclusive governance. Slide 4. Now we go to what is the study itself. So this study is actually give you pictures of how the sea level rising give impact to services like education, health, and social. And also at the set, so we try to give a profile before the sea level rising, how is the public services are delivered and how they are available for people. And then we go to the impact we go to the specific impact for education, health, and also social. And then at the end, we try to create a policy which can be used as reference by local government in developing their policies, planning, and also budget. Slide 5. The methodology of this research, we actually use the quantitative and qualitative research, and there are collaboration in between governments and data analysts, and also social CSOs, to ensure that the result of this research is actually evidence-based, and also at the same time it's also realistic to what happened with the situation in the field. So slide 6. Now, let me explain to you here. The screen capture that you are seeing is actually based on several data that gathered by the Directory of Water Resource, and then also from the UN Global Polls, which presented in the platform of sea level rising by Sepakat system. So the blue area of this map shows you the potential area of being flooded or being impacted by the sea level rising. So we can see in this screenshot, one of the cities that face the highest risk is actually Mataram and also Bima. Next slide, please. Now, this is the baseline situation. So before sea level rising, this is what we had in the community. This is what exists. This is what actually available in the community, and it helps a lot. Now we go to slide 8. We go to what happened if there is a sea level rising for 1 meters. You can see that there are several areas in the coastal. It begins to flood. It has impacted several areas as well. It has impacted several activities, and moreover, it's also impacted the situation, the infrastructure, where it diverts commute when people try to commute around the coastal areas. Now, the next slide, we try to simulate double. So first we have 1 meters. Now we try to simulate in 2 meters. And you can see that there are several abstractions happen. So it's not now only flooded, but it's also now abstraction of activities where people have to divert their activities. Children are affected when they go to school. Primary health care, they stop the services. And if you can see here, while on the other hand, we only double the increase of the water level, but it has significant number on the victim or the impact. Yeah, so very, very significant. So slide 10, we increase the simulation to 3 meters. And now we are talking not only abstraction, but we are talking about destruction. So there are infrastructure are being affected, people are being relocated, activities are fully stopped. So these are the impact what happened when the sea level rise for 3 meters. Now we go to the next slide, which is the finding of this research. So in general, the people who are affected are those who live in a low coastal line. It means that it's in the further part of the land closest to the sea. They are very much impacted with the sea level rising immediately when the sea level start rising. Now, people with disabilities, informal workers, they have to start to divert their livelihood because they have to come up with other alternative. Because informal workers, they don't have formal jobs. So they have to divert to get more income. People with disabilities, their mobility is being surrounded by the broken infrastructure, and also women who are mainly breadwinner are also affected because they have lots of responsibility, double or even triple responsibility. When on the other hand, they also have to solve the problem of the flooding. Now, next slide 12. What is the funding that we have in the education? Yeah, this is also interesting because most of the damaged education facilities are actually the elementary school, which also affect the first grade elementary school student, and mostly also for people, students with disabilities, they don't have any alternative when their school is flooded, when their school is damaged because of the sea level rising. They cannot just move to other school because of their needs and also the accessibility. So it's very difficult for them to find another alternative.
We have 1 minute left. I'm sorry.
So next slide. In terms of health, it's similar to the school. The primary health care is also affected at first, and then the flooding itself does not only affect the infrastructure but also affect the surface of caring. For example, people with critical illness, they will lose their caring, their sustainable caring, and since that like 56% of them does not have insurance. Again, they don't have any alternative that going to rather than going to primary healthcare services. And then for the social services, it's obvious because of the flooding, people needs to find other alternative on how they can make their livelihood, they can make their income, and at the same time, they also have to think how to relocate themselves. So what is the recommendation? Next slide, please. So in general, we need to strengthen the disaster risk reduction planning for us, and it has to be inclusive as well. The infrastructure needs to be accessible. We also need to have a good shelter, and also early warning system is also needs to be applied within second. And then this is also important that the cooperation in between government, civil society, and then academia as well, it needs to be increased to come out with how we can actually avoid this disaster. And for education, some of the recommendation you can read up at the slide, but one of the most important thing that we want to bring out is the environment situation, the global warming situation, and also disaster risk reduction. We really think that it should be in the curriculum of the education. So students, they will know very early about the risk of sea level rising and also other disaster. And we should also expand health services, and also education for health is very important. And then in social sector, we need also to come out with GHI-based insurance services. Yeah? And then we have to also figure out how to relocate people who are in a very high risk. And then slide 16, this should be one slide to last slide. So we just would like to remind you that sea level rising is not about only environmental, but it's a cross-cutting situation where people needs to pay attention. We need to be very inclusive in taking over this situation, and we need to collaborate in between organization and also institution. So last slide, thank you very much. For more information, you can contact us at Scala. Thank you very much.
Thank you very much. Thank you very much for the complete presentation, for the vital impact between environmental condition and social well-being. You may be returned back to the seat, and we will later during the Q&A session, we will invite you back to the stage again. So for the last speaker, last but not least, for our third speaker, we turn to the area of vaccine research and child health. So our third speaker is Dr. Putu Aditya Wiguna, Master of Science, clinical pediatrician. He is our D colleague who is a lecturer, clinician, and researcher. Clinician, pediatrician, and also Masters in Clinical Medicine at Gajah Mada University. He began his career as a general practitioner at Tanjung Community Health Center, or Puskesmas Tanjung, in 2009 until 2011, which is in North Lombok, and has served as a lecturer at our D University since 2011, and also as a pediatrician at the University of Mataram Hospital since 2019. Today, Dr. Putu Aditya will present on a phase 3 observer blind randomized control study of the safety and immunogenicity of SARS-CoV-2 protein subunit recombinant vaccine in health of the children aged 12 to 17 years in Indonesia. This presentation will highlight not only the clinical findings that contribute towards our understanding of how the vaccine are effective and safe in children, but also learn about the various challenges throughout the research and how Dr. Putu and his team addresses those issues. So please join me in welcoming our third speaker, Dr. Putu Aditya Wiguna.
Thank you. Thank you, Dr. Dewi. Good afternoon. Thank you for having us to present our research in the vaccine for COVID. In the next 10 minutes, all of you gonna hear my complaints about how to perform vaccine research in our setting. So our dean is here, so he can listen to our complaint. So the first thing that we perform is to evaluate immunogenic non-inferiority immune response of SARS-CoV-2 neutralizing antibody of biopharma vaccine compared to the vaccine control at the 14 days after primary series. That means we inject the patient with our vaccine, Indovac, our homegrown vaccine, at the first 2 weeks of vaccination, and after that we're gonna evaluate that at the 3, 6, and 12 months after primary series vaccination. So we also evaluate the cellular immunity, and of course for the vaccine we're gonna need to ascertain about the safety of the vaccine. This is the challenge to performing clinical trials in low resource setting. We have concluded there are 7 hurdles we need to overcome. The first is the infrastructure and logistics. This is our clinical trial room. It was in ruin after 2018 earthquakes, and in 2022, this is our condition. So we need to repair the room. We have inadequate clinical facilities and laboratory spaces, so we need to work together with the PRODIA, the most prominent laboratory in Indonesia, and also work with the Gajah Mada and Udayana laboratory to test our result. We also have unreliable electricity, water supply, and internet connectivity, and limited cold chain capacity for investigational product and specimen. To ascertain the cold chain capacity, we work together with the private sector to make sure that our product is still in the cold chain protection for the quality of the vaccine itself. We also have a poor transportation network affecting the site visits and sample transport. This is also, we work together with the existing private laboratory to transport our sample. The second one is the regulatory and ethical oversight. We need to, vaccine research is a very heavy and regulatory and ethical oversight. We need to have ethical approval from the Gajah Mada University Hospital, Mataram University Hospital, local research regional and innovation agency, and considering that the COVID vaccine is a sensitive political issue, we need to get approval from the National and Political Unity Agency, local government, and health department. But in having regulatory and ethical oversight, we have a trouble in the fragmented national and local regulatory authorities. We also have a lengthy protocol review and approval timeline, and variable ethic committee expertise, and lack of harmonious guideline across nation. The one that work in West Nusa Tenggara doesn't work in the Bali, it doesn't work in the Padang. Because we are a multi-center site, we have to be able to finish it at the same time, around the same time. For the human resource and training, in the low resource setting, not only we have a low research, but low human resource also. We have a shortage of staff trained in good clinical practice, high turnover among clinical, laboratory, data management personnel, and supervisory capacity stretch across multiple roles. So in order to address this, we do our in-house good clinical practice. We have also maintain the clinical laboratory and data management personnel in a small but compact team. And we already have them stay in our team for 5 years. And supervisory capacity, we invite and work together with several universities to help us having a supervisory capacity. For the participant recruitment and retention, we have a low literacy or hard literacy that impending the informed consent. The parents actually, some of them have an illiterate, and some of the child doesn't have a parents because most of our subject stays in the pesantren, and most of them are not with their parents but with their guardian at the pesantren. And there is a cultural belief or mistrust on vaccine research, which is still hindering our research even today, and difficulties in finding eligible population that haven't vaccinated by the national COVID vaccine program, because there's a mismatch of vaccine record by the national policy and the actual vaccination record, and the challenge in maintaining follow-up for long-term endpoint due to geographical issues. The supply chain and data management also hinder us, but we have a complex import regulation for investigational product and devices, the stock out of essential consumable and laboratory agents, especially during COVID, and paper-based data capture prone to transcription error, and the backup for the paper-based, which is electronic-based, is prone to the data miss in there. The limited capacity for remote monitoring and real-time data validation, especially during COVID, make us rely mostly on remote meeting. But fortunately, due to the easement of the COVID in the later, after the Omicron phase, we are having good real-time data validation. The financing and sustainability is also a major hurdle in the vaccine trial. The reliance on international donor and external sponsor hinder us at the beginning, but after we secure the sponsors, we are able to do this vaccine trial. Unfortunately, the low local government investment in clinical research infrastructure hinder us, but with the political support, we can get more funding by the local government. The cost overrun also impacting budget predictability and the limited cost recovery or revenue generation, because vaccine is a long run, so that's discourage people in pursuing research in this area. Thank you.
I'm sorry, Dr. Putu, you have 2 minutes to go.
Thank you, Doctor.
Okay.
The quality assurance and monitoring, we work together with the Equilab as a monitor and BPOM, the Indonesian Food and Drug Administrator, as an auditor. In this research, there are 2 sites that audited by the BPOM. One of them is the Mataram, and we passed the auditor by the BPOM. This is the simulation and site initiation visit. This is the first subject enroll. The room is now livable. This is the BPOM inspection, and data safety and monitoring also done remotely. And archiving is we are doing the paper-based and the electronic-based record due to the inability to make sure that the data in the electronic is safe. This is the result. This is the neutralizing antibody before vaccination. This is the neutralizing antibody 14 days after the second dose, in which we achieve better than our competitor, our control. And this is the primary analysis for the neutralizing antibody. This is the secondary analysis for the 3 months, 6 months, and 12 months, we achieve a significant better result than our control.
I'm sorry, your time is up.
Yeah. Thank you, doctor. And at the end of the day, doing the vaccine research in a very limited resource is challenging, and by working together, we can achieve that result. Thank you.
Thank you so much, Dr. Puti. It was a very comprehensive speak, and I'm sure there will be many questions. You may be seated, and then we will. You can come back later on at the Q&A session. Thank you so much, Dr. Putu. And so now, because we still have at least around 5 minutes for Q&A, I'm sorry. If you may come back again for Dr. Putu, I'm so sorry about that. Dr. Putu, Ibu Yuni, and also the coordinator of GHI. I'm sorry, Dr. Putu, that was my bad. If you'd like to join me in the Q&A session. Thank you so much. Sorry, Dr. Putu. Pak Cakap lihat di sini. Okay. So we have 5 minutes for Q&A. I'd like to invite the audience and in this room and also via our online platform, perhaps 2 questions. When you ask your question, please mention your name, the institution that you are from, and also to whom the question is directed to. So does anyone have any question to our lovely speakers that are with us this afternoon? Okay, we have one question. Thank you.
Thank you. Good afternoon. Thank you for the speaker for the material that was explained to us. Sorry, my English is not good. I am Novi, in student of public health in Undram University. The question is for Miss Yuni. Your application is so interesting. I am now I'm work at primary healthcare. That was one of the challenges is DBRS kunjungan posyandu untuk baik itu penimbangan ataupun immunization. This lack or antenatal care of the pregnant in our public health is lack. There's no data how much the pregnant or the child that was become the target that was want to dilayani di posyandu ini. Mungkin aplikasi ini bisa kami gunakan untuk di rural, jadinya bisa dijadikan sebagai data karena selama ini bidan dan teman-teman vaksinator masih kekurangan data terkait sasaran-sasaran itu, sehingga mungkin dengan aplikasi ini bisa memudahkan sehingga when the target that not come to our posyandu that will get the message when they must come to puskesmas to get antenatal care. Thank you.
Okay. Thank you, Ms. Nafi, for the interesting question. So we'll give to Ms. Yuni. Would you like to answer the question in regards to the application that has been developed?
Thank you for the interesting question. I think in the primary healthcare, the challenge is, as you mentioned, Ibu, So what we do, actually, using a single application may not work. So what we do is combining multiple approaches to enable us to know when the clients need to visit, let's say, Posyandu. We need to approach the family members, including the mothers, through WhatsApp reminders, call reminders, or even if the family is not having the, kind of digital application, we need to send person to home visit. So actually what we do with this digital intervention is not necessarily everything need to be using application. What we do still, sending people, sending human to visit the home. That's when we not meeting or if the family doesn't have the devices or handphone. But if you ask me, is it can be used for connecting between community with the facility, meaning if you find a person in the community, you find a gap, then can follow up to visit the Puskesmas or Poskesdes or Pustu, whatever the name of the primary healthcare network. Yes, it's possible, but it is not like single application work. But multiple tools are working together, even to sending people to the home. It's not like manual job. So we need to understand the task of a person, then make it automated. So that's why I mentioned this application, not only single, but it's ecosystem that works together. And yes, it can be applicable for Puskesmas or Pustu or Posyandu, or even can be used by the midwife or cadre if they are digital literacy. But again, we need to understand the flow first, and the second, how the best approach. Tools, digital technology is only tools. Human-to-human interaction is still needed in our context, I believe.
Thank you very much, Ms. Juni, for the answer. So is there any other question from the floor? Okay, Professor, thank you so much.
Thank you all very much for a very entertaining session. I actually have a question for speaker number 2 and speaker number 3. They are somewhat related. So for speaker number 2, I was very interested in your modelling about the prediction of rising levels of water. I'm interested both in whether you've looked at that, what happens when a cyclone comes through with higher water levels and the impact that that will have. And then I'm curious about the ethics around how do we deal with people that are more vulnerable to kind of disasters coming through. And that then goes to speaker number 3. I'm also interested about the ethics of vaccine trials in low resource environments. Did that make sense?
Thank you, Professor, for the question. So for speaker number 2, sir, would you like to kindly answer in regards to how to deal with the ethics in regards to the application, also the modeling cyclone in vulnerable community? Jadi
Thank you very much. Sorry, I wasn't clear with the audio because I think the speaker needs to be a bit louder, but it's okay. Here's the thing: when it comes to ethical situation, it's best for us to actually come to the person or the group themselves and ask directly to them how are these going to suit them. So very, very important that we involve them, we engage them, and also we ask them what is actually suitable or not suitable that can be done within the situation. When we would like to ask them, let's say if we're thinking about relocation because they are at risk of flooding, and we come we come to them and ask them if they are being relocated, what are they going to do? What kind of livelihood they are going to develop? Who are they going to work with? That is very important question that we have to address to them. Sometimes we are too busy thinking about what best for them instead of what asking to them what is their needs. So in terms of ethical, we highly suggest, as what Scala always do, how to ask them and to actually come with every evidence that comes from the community and utilize those evidence, combine them with data synchronization to come out with a better solution for them. Would that answer your question, sir? Yeah? Okay, good. Thank you very much.
Thank you very much. Dr. Putu, would you like to answer the question for ethics in regards to the vaccine trial?
Thank you, Professor. The ethical process is quite lengthy and rigid process. We got our protocol got an ethical assessment from the national level, and then we goes that to local levels, and we tweak our protocol based on that suggestion to fulfill the rigid of ethical qualification for the vaccine research. The problem that we face in this is that the children, some of them does not have a parents, and for those that does not have parents, we need to search for their actual guardian, and for those that live away from their home, we need to get informed consent and consent through either by phone, WhatsApp video call, or Zoom call, and so that we are able to face with their real guardian or parents. And some of them doesn't have any. And for those that doesn't have guardian or parents or people that actually formally in charge for them, we are not taking them as a subject for our research, because that's a gray area in the ethical consideration. Thank you, Professor.
Thank you, Dr. Putu, for the answer. Does that answer your questions? Or perhaps there's a follow-up question from that? Okay. Okay, Professor, thank you. Okay, so turns out that we still have some time. So if there's any other question from the floor or perhaps through online platform, we still have 2 more questions perhaps from the floor. Okay.
Okay, I have a question for Ibu Yuni. So I am very much interested with what you did in SID. It's very helpful, and I believe that digital can be a solution for many people, including in remote area. I would like to ask about the technical issue. While you are approaching the mothers through the digital interventions, what will these practitioners do when they're not very responsive, when they're not very responsive to the reminders and so on? So even though they have the device, what will you do? To what extent they will be picked up by the puskesmas or any healthcare practitioners, and like what criteria that they will pick up, or what about the person who have the device but they don't really responsive to that? Yeah.
Okay, thank you. So it was about, so if there was no response in regards to from mothers after they've been contacted with digital platform, then what's then done next?
Thank you. Thank you. That's interesting. Another interesting question. So our internet or kind of device ownership in Indonesia is quite high. Yeah? So let's say every family supposed to have one phone. But we also found, I believe I have a team here who daily basis like connecting with the community, not only through phone call or WhatsApp, but they also scheduling the person. We call it like community health promoters. So they are trained, so they can like talk with the community and able to be sent out to every house or posyandu, because although the penetration of internet is quite high even in NTB is quite high, but they seems like they change numbers somehow. Then the phone is owned by the husband, for example, or even if we send WhatsApp, it's suddenly the children they usually play game, right? And the WhatsApp says, okay, it's been delivered, but it's not received by the mothers. So essentially, the technical issues become, we need to able to have a daily assessment of those application, or you need to assess every day the success rate of your WhatsApp. Is it being delivered? Is it being answered? Is it being rejected? And so on. At first, we do this call center. They said like, is it like pinjol, pinjaman online? Why you bother us and so on. But after we address the issue, oh, I think this number needs to be saved through your phone, your contact, and then the increase in engagement, the engagement increases. Every day is about doing evaluation. So the loop of evaluation never completed, because this is iterative process. So every day our team doing like 10% QC, quality control, to make sure whatever is sent is received, and whatever is received is read and understood by the mothers or the family members. If they don't have the phone, our scheduling, our scripting is actually saying, okay, you need to do home visit. So the next day, the dynamic worker support, as I mentioned, the people need to be sent out. So not forcing yourself to connect with phone, but send the people, and it increased the engagement. So you need to get those evaluation everyday basis, and the QC is important. Quality control, every 10% of the numbers that you contacted that day, you need to check. They received, they read, they understood. So that's the way we do it. Again, the tools is to help us, but the evaluation remain. If you're not reaching them out, use the community health volunteers or send people to their home, and it works. Thank you.
Thank you very much for the answer, Ms. Unit. So it turns out that our time is up for this session. So today's presentation have illuminated how innovation, resilience, and evidence can shape the future of health in island regions like Lombok. From harnessing data-driven technologies, as our first presenter mentioned, to strengthening primary healthcare, to understanding the far-reaching impacts of sea level rise on basic services, and advancing vaccine research that safeguards our children's health here in Lombok and also in Indonesia. Each speaker has shown both how Lombok can be beneficiary and also a contributor to global health innovation. These insights not only guide us towards stronger and a more inclusive health system, but also spark new research collaboration that bridges science, community, and also sustainability for small islands. So this concludes our spotlight session, Emerging Voices and Innovation in Islands and Tropical Health. Thank you to all our speakers that have shared their work here in Lombok and who have participated and also to all our audience here who had participated in this session. I hope this discussion will inspire continued collaboration and also innovation across the region. We hope everyone has had a wonderful two-day conference, and please enjoy the rest of the program. And with that, I would like to hand the floor back to our MC. Thank you very much, and give a round of applause for all our speakers today.
Thank you to all the speakers and moderator for an insightful discussion on the Spotlight session, Emerging Voices and Innovation in Island and Tropical Health.
To conclude this spotlight session, we would like to present a token of appreciation to our distinguished speakers in recognition of their valuable contributions to the GHI 2025. Please come forward to the stage.
The plaque will be presented by our moderator, Dr. Dewi Suryani. Please come forward to the stage.
To all the distinguished speakers, we please you to come forward to the stage to have a plaque that gonna be presented by Dr. Dewi Suryani. Pardon me, to all the distinguished speakers, we please you to come forward to the stage to have a plaque that already presented by Dr. Dewi Suryani. Please give a warm round of applause. Once again, thank you so much to all the speakers for the valuable contributions of the GHI 2025. Ladies and gentlemen,
We have arrived at the grand finale, the awarding and closing ceremony.
now we're going to announce the winner for the best poster and oral presentation. Starting with the winner for poster presentations in undergraduate category.
For the third winner, congratulations to Muhammad Rifki.
To Muhammad Rifki, please come forward to the stage. For the second winner, congratulations to Fauzan Faki. To Fauzan Faki, please come forward to the stage.
And for the first winner, congratulations to Imade Putra Biantara. Please come forward to the stage.
For all the winners, we may please you to have a place in the center of the stage. We would like to invite the chairperson of the 4th GHI 2025, Dr. Mutia Chandradai, to the stage to present the award for the poster presentation in undergraduate category.
Congratulations to all the winners. Please give them one final round of applause. For all the winners, you may please be seated.
Ladies and gentlemen, we now move on to the winner for the poster presentation in postgraduate category.
Congratulations to
And for the second winner, congratulations to Rifki Arafah Huda. Please come forward to the stage.
And for the first winner, congratulations to Please come forward to the stage. For the first winner, Zakiuddin Abdul Azam, please come forward to the stage.
We also pleased to Dr. Mutia to present the awards for the poster presentations in postgraduate category.
Congratulations to all the winners. Please give them one final round of applause. For the winner, will you please be seated?
And now for the last category is in poster presentation, which is the general category.
For the third winner, congratulations to Wahida Hajrin. Please come forward to the stage. For the third winner, Wahida Hajrin, please come forward to the stage.
For the second winner, congratulations to Adriana Rosmalina. Please come forward to the stage. We also pleased to Dr. Mutia Chandra Devi to present the awards for the poster presentations in general category.
Congratulations to all the winners. Please give them one final round of applause. For the winner, you may please be seated. Ladies and gentlemen, next we will announce the winner for the best oral presentation, starting with the undergraduate categories.
For the third winner, congratulations to Lania Pratipa Untari. Please come forward to the stage.
Winner. Congratulations to
And for the first winner, congratulations to Baik Khairatinisa Okari. Please come forward to the stage.
we would like to invite the Dean of the Faculty and Department of Sciences, University of Mataram, Dr. Ati Samson, to the stage to present the awards for the best oral in undergraduate category.
Congratulations for all the winners. Please give them one final round of applause. To all the winners, please be seated.
Moving on, we will announce for the winner for the best oral presentations, postgraduate categories.
For the third winner, congratulations to Asma Halil. Please come forward to the stage.
For the second winner, congratulations to Juicy. Please come forward to the stage. Once again, for Juicy, please come forward to the stage.
And for the first winner, congratulations to Clara Imaniar. Please come forward to the stage.
To Dr. Arfi, please present the award for the best oral presentation, postgraduate categories.
Congratulations to all the winners. Please give them one final round of applause. To all the winners, please be seated.
announcement. Next, we will announce for the best oral presentation, general categories.
For the third winner, congratulations to Ratri Kusuma Wardani. Please come forward to the stage.
For the second winner, congratulations to Iputu Gede Satyawati Saputra. Please come forward to the stage.
And for the first winner, congratulations to Putu Suita Sari. Please come forward to the stage.
To Dr. Arfi, please present the award for the general categories.
Congratulations to all the winners. Please give them one final round of applause.
To Dr. Arfi and all the winners, please be seated. Congratulations to all the award recipients. Next, before we close the fourth GHI 2025, we kindly invite the Dean of the Faculty of Medicine and Health Sciences, University of Mataram, Dr. Arfi Shamsun, to deliver the closing remarks. To Dr. Arfi Shamsun, the stage is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Dear distinguished guests, colleagues and friends, as we come to the close of the fourth International Conference on Global Health and Innovation, allow me, on behalf of Faculty of Medicine and Health Sciences, University of Mataram, to express our deepest gratitude to all of you. Over the past days, we have exchanged knowledge and experience with experts from Indonesia, Australia, Japan, the Netherlands, Nepal, and beyond, with more than 140 abstracts presented. This conference has created an inclusive platform where different perspectives intersect and drive innovation in global health. I extend my sincere thanks to all speakers, participants, stakeholders, and the organizing committee for making this event a success. May the collaboration and connection from here continue to advance global health innovation in the years ahead. Thank you, and we look forward to welcoming you again at the next GHI in 2027. Assalamualaikum warahmatullahi wabarakatuh.
you, Dr. Arfi, for the closing remarks.
Finally, for the official closing of the 4th International Conference on Global Health and Innovation 2025, we kindly invite the chairperson of the 4th GHI 2025, Dr. Mutia, to deliver the closing remarks.
I don't have a lot to say, don't worry about it. Dear colleagues, friends, and members of our organizing committee, as we close the 4th International Conference on Global Health and Innovation, I would like to thank our speakers. Thank you for sharing your knowledge and inspiring us all the way to our humble island of Lombok. I would also like to thank our participants. Thank you for your energy, curiosity, and willingness to engage. And above all, I want to thank the organizing committee. From the months of preparation, countless late nights, well, that was from countless late night, and endless details, your commitment has been the backbone of GHI 2025. You have shown what teamwork, resilience, and shared purpose can achieve, which is the very spirit of what GHI is. And I also hope that the networks and friendships formed here in Lombok will become stepping stones to future collaboration that extend well beyond this conference. So GHI 2025 is not just an event, it's a community, and you are at the heart of it. So thank you from the bottom of my heart for making this vision a reality. See you in the GHI 2027.
Thank you so much to Dr. Mutia for the concluding address.
And with that, we officially conclude the 4th International Conference on Global Health and Innovation 2025.
On behalf of the organizing committee, we thank all the distinguished speakers, moderators, and participants for your valuable contributions.
Thank you, and see you at the
5th International Conference on Global Health and Innovation 2027. Matur Tampiasi.